3 minutes. It's very important to check the distal overpass, and now you can insert the shunt. You can verify the function of the shunt, because we are using the Pruitt-Inara shunt. Yes, here you can see. And after you have the time to do what you want. You can perfection the carotid endarterectomy with a peeling of the side of the carotid, and after you can put a patch angioplastic. Normally we can use an PTFA. So summarizing our technique, we use carotid endarterectomy in general anesthesia with continuous EEG monitoring, and in every case we use a routine delayed shunt insertion. And after this, the finish of the procedure is with unpatch. In case of carotid stenosis associated with kinking or coiling, we prefer to use the eversion technique you can see in this perioperative picture. The section of the origin of the carotid, internal carotid artery, the eversion, and you can see perfectly the distal overpass. Also in this case we use always the shunt, and finally the reimplantation of the internal carotid artery at the common carotid artery level. So this is our result about a series of more than 1,700 patients, asymptomatic patients with carotid stenosis more than 70%. And I would like to underline that we are making a lot of asymptomatic patients, but these patients are not always, but in the majority of the case, present the morphological characteristic of the plaque, as for example soft plaque with hemorrhagic complication in the side of the plaque. So are asymptomatic patients, okay, but are patients with high risk of stroke. In this paper, we can see that in 10 years of experience, we have one relevant neurologic complication rate that is less than 1%, 0.6%. But a very important thing, a very important message that you can have with this paper, and these results are independent of the volume of the operator and the experience of the operator. Because we control these results in all members of my team, the older and the younger surgeon. And if you have one standardized technique for carotid revascularization, the final result might be this. So this is not important if I am the first operator or the first operator is the youngest of my collaborator. So in conclusion, a careful perioperative risk stratification, appropriate indication and proper surgical technique help to make a carotid endarterectomy an almost completely safe procedure. Carotid endarterectomy is an effective and durable procedure, and today is still considered the gold standard in both symptomatic and asymptomatic patients. Today, it is in my opinion, carotid angioplasty and stenting is not an alternative to carotid endarterectomy, but as to be considered as a complementary method that allows to treat challenging case of carotid endarterectomy for medical or anatomical reason. Thank you very much for your attention.
Next. Well, thank you very much. It was a wonderful presentation. I especially like the part where you say that you are looking at EEG. I'm a neuroscientist, so I'm interested in that. You're looking at the EEG while doing a CEA. We routinely do that. And electrical failure is the first thing that you encounter before you actually have a ischemia. So most of the time, if the stenosis is very, very high, let's say 80%, 90%, there's a need of a shunt. We have never encountered a need of shunt. So we don't use shunt, most of the time. And secondly, what is your thought about stump pressure? Do you measure stump pressure?
No, I can explain. So, regarding the first question, EEG. The problem of the EEG is not to read the modification of the EEG. The sign that the EEG can give you is, after your clamp, something is changed. So when, obviously, not the frequency, not the level of the arm. So this is the first. The second thing is that EEG is not a system that covers 100% of the ischemia. It's only cortical. You don't have problem of the deep tissue. There's no problem about the trunks of the brain. So, after our experience, I said that is a multi-steps process. In the first, we started to use EEG and shunt. Shunt only with EEG shows a modification of the EEG sign. But for this reason, the complication rate was near 2%. So in our experience, we think that another system have to be associated with EEG. And the other system is the routine use of the shunt in the lighter way. With this, the protection of the brain is total. And EEG can show you if your shunt is working or not. And there are some cases when we change the shunt, because the shunt might be, for example, the touch one coiling position of the artery. So in this case, you have the shunt. You think that is working, but you have not one vascularization. Regarding the second question about the stump pressure. The stump pressure for me, is not a good method, because stump pressure shows only the first moment of the clamp. And you don't know if during your procedure the pressure at the brain level is the same. So you can have one good stump pressure 30 seconds after the clamping, and after 3 or 4 minutes the stump pressure might be different. And you can't stay to check in every moment the value of the stump pressure. So in my opinion, no. Now we are use the NIRS in association with EEG in order to verify the oxygenation of the frontal, but we put together.
Yeah.
Well, I basically do cardiac surgeries. So my question is regarding if somebody is undergoing cardiac surgery, say bypass, along with carotid endarterectomy, then does the indication change for the carotid endarterectomy, or it doesn't change? Because we change the physiology during the surgery. So I just want to know what's your opinion.
My opinion about this, I don't remember, but more than 10 years ago, we published a paper about this problem, the association carotid endarterectomy and coronary artery bypass. And with our friends, the cardiac surgeons in our clinic, we decided to treat together in the same time. First, I performed the carotid endarterectomy, but I don't close the skin, but only my colleagues do the coronary artery bypass. I come back, I control the side of the lateral cervical incision, because you have a great heparization during your bypass clamp, coronary artery bypass. So this is an opinion. The problem is when you have both stenosis in both arteries, more than 90%. So in this case, you have probably have a protection of the ipsilateral brain, but don't have protection in the other. And you know that you can have one problem also on the other. And normally we treat patient only when the patient is symptomatic for carotid stenosis, or patient with stenosis more than 90%. In other case, with patient with 70%, for example, in the last time, our cardiac surgeon preferred to do the coronary artery bypass, and after we do the carotid endarterectomy. Or, if the condition of the cardiac of the patient is not so bad, we will do the carotid artery endarterectomy, and after the coronary artery bypass. No CAS immediately, no coronary artery angioplastic and stenting, for the problem of the use of the drugs, the antiplatelet drugs.
Thank you.
You said you would do an endarterectomy on a high risk plaque in an asymptomatic patient. How do you determine the risk of the plaque in an asymptomatic patient?
It depends on the morphological characteristic of the Doppler scan. If you have one soft plaque, not a hard plaque, and in the majority of the case, the soft plaque is the sign of an hemorrhagic complication in the side of the plaque. And for me, this is a patient that has a high risk of instability of the plaque, and also the possibility of an embolization with the risk of stroke.
So do you have an objective measure of the lucency of the plaque?
Yes. The characteristic that my colleagues that do the Doppler scan show me this, and I accept this. But with stenosis, more than 80%, not 60. Okay.
Thank you.
Next speaker will be late. Next speaker.
Yeah, let's go to the next. Thank you very much. Thank you very much. And I think about Dr. Trehan is going to talk about what Dr. Himalayan just asked.
Due to time constraints, we'll be taking the questions at the end of the session. Now I invite Dr. Naresh Trehan for his talk.
Good morning. So, Dr. Greco has given most of my talk already. Oh, sorry. Good morning. So, Dr. Greco has given most of my talk already, so that I will just add whatever we have to, in our opinion, with our Indian experience. So, let's see, okay. So stroke burden in India, or around the world first, is the third leading cause of death around the world. It's also the leading cause of death and disability in developing countries. 87% of the global strokes happen in the developing countries. In India, we estimate about 1.5 million cases of new acute stroke occurring every year. Of course, the reasons may be multiple, not only related to carotid disease, but other factors also, but majority of them are basically due to carotid disease. So, 30-day cause mortality rate of stroke is 41%, accounts for about 1.2% of all deaths. So the gravity is huge, no question. Now, if you look at, like I said earlier, that what is the state in different segments. So if you have less than 60% stenosis but carotid disease, and some definition of the quality and the physiological characteristics of the plaque do determine whether we consider them as benign or basically acute stroke incidence can be higher. And like Dr. Greco was saying, that the duplex scan actually is very helpful in determining the physiology of the plaque. But if you have more than 60% to 99% stenosis, then the stroke rate is extremely high, in spite of the fact that we are using antiplatelets and also statins to try to prevent or see the rupture of the plaque, which we know that statins do stabilize soft plaques. They do create fibrosis in soft plaques. But in spite of that, the incidence has not really changed in the last 20 years because the disease is even more aggressive today than it was before because of the rising incidence of diabetes. So whatever we may have gained by way of our medical therapies, we have lost to diabetes. So, I'm going to address the fact carotid disease along with CABG. So we have the overall risk of stroke in a CABG asymptomatic patient who has carotid disease less than 60% is still 2%. 3% among patients who have asymptomatic unilateral disease greater than 50% or even higher, and we will subdivide that further. So it is 5% in patients who have bilateral disease, which is significant, and 7% among those with carotid occlusion on one side. So this data has been very extensively studied around the world, many studies done, and I think Dr. Greco gave one of the analysis. So now we are saying if you narrow down to carotid and coronary artery disease, Brenner et al., they've done a lot of studies. But for India, what is relevant for India, we at Escorts Heart Institute, which I founded and then was there for 20 years, we screened over 6,000 patients, and we found these are patients who were admitted for CABG. 6% of those patients had carotid disease. And we have now replicated this study in our new institution, Medanta, and we have found almost similar results. Now maybe a little less than 6%, and like we say, it's about 4.5% now. So our experience showed us, after screening 28,000 patients, that 4.5%, that is 1,256 patients, had carotid disease. Out of those, 354 were isolated carotid disease, and the distribution of right and left was almost equal. On the other hand, 902 patients had CABG and carotid disease enough that they required both the procedures to be done together. Out of that, majority of them were unilateral CEA, but 4 we did combined on both sides. Now this is the compulsion that we felt, that if the incidence of stroke from CABG in non-carotid disease patients or mild carotid disease patients was 2% and above, and with critical carotid disease, it was somewhere between 3 to 7%. So the justification that we felt that in centers, much like what was presented from Padua, that if there is enough experience in the full team to do carotid endarterectomy along with CABG, and your results show less than 1% stroke rate, then it behooves you to do combined, and rather than not touching it if it is significant. So the classification of what we felt was people who have had TIAs, strokes, and people who had no symptoms but had greater than 70%, 75% stenosis were the candidates who we were actually entertaining. The protocol, of course, is duplex scanning, CT, MR, angiography wherever indicated, for most of the patients who have greater than 50% stenosis. You need to do that to determine whether they've had strokes, or are they asymptomatic, or is there any other concomitant disease further up in the vessels, at the smaller vessels. So CA indication we used basically was greater than 70%, even if the patients were asymptomatic. CA is also indicated in stenosis greater than 80% and patients who are asymptomatic. Sorry, I did miss, it was 70% if they are symptomatic, 80% even if they are asymptomatic. CA is contraindicated in cases where total occlusion is there because it is not going to benefit, or there is significant stenosis further down on the internal carotid artery. So the definition of severe stenosis becomes greater than 70%. Symptomatic is history of stroke, TIA, or documentation on your studies. Perioperative, we use a new focal or global neurological deficit with radiological evidence of fresh infarct within 1 week of the CABG. So with that criteria, we established in what stage we should do the CA first and then CABG, or reverse, or combine. So basically we came to the conclusion with our own experience that neurologically symptomatic greater than 50% carotid stenosis should be combined. Patients with evidence of cerebral infarct or CT scan in the distribution area of that culprit vessel should be done combined. And asymptomatic patients with bilateral carotid stenosis greater than 70% should be done. Concomitant surgery should be done. So CABG in all unstable patients, left main CAD or severe triple vessel disease was the indication, but we on our own experience established that carotid endarterectomy on symptomatic side is the most frequently done. In asymptomatic patients with CA on tighter side of the first, and MR angio to decide the culprit vessel. Vessels flowing to dominant hemispheres were also a consideration of which sequence we will adopt. So, the operative procedure was first isolated, like we said, we divided it up into CA, preferably under regional block. If we are going to do CA with CABG, of course it's under general anesthesia. And we do the CNS, the bitemporal EEG, capnography. Pulmonary artery pressure is not really, the reason for that is not related to the carotid, but for any unstable angina or progression of ischemia while you're doing the carotid in the cardiac side. So all these monitorings were done in all cases, and this is a representation of on the left is what degree of stenosis that you would experience most of the time, and on the right is a post patch or post endarterectomy image. So we do now. Is this going to move? Can you? This is a video. Hello, hello. Can the video? Okay. So it's quite similar to what was shown by Dr. Greco, except that we have, and the question was raised, we do not use a shunt routinely. The thing that we do monitor is, as we said, that there is capnography and the EEG, but what we do have learned over a period of time is how intense or what pressure the retro flow is. So if we have a very sort of robust, and we used to measure it first, like the stump pressure and all that, but then right now because we do it so often that we have actually abandoned that monitoring every time, because they're like Dr. Greco said, that the stump pressure changes over a period of time. But one thing we do routinely is that we will maintain the arterial pressure, mean arterial pressure above 70 at all times. So even if we have to use some inotropes to do that. So that's what we think is a protection. Except in patients who have critical bilateral disease. So we will always do the one which is more severe, or the one which is going to the dominant hemisphere, but at the same time, if there is significant disease on the contralateral side, we would then use the shunt routinely. Now, as you may have noticed here at the end, very frequently we will use a vein patch because we've already harvested the vein for CABG. And if it's not, if we are doing total arterial, which is also quite frequent, then we will use a Gore-Tex patch, like you said. So PTFE is the choice. There is no difference in outcome. And we have followed our patients for many, many years. The fear was that if the vein is too sort of fragile or flimsy, then we don't use it, of course. So we will use it more from the lower end, where the pressure is higher, lower end of the saphenous vein. So anyway, this is the demonstration. You've seen it again. Now, mortality was 0.43%. Neurological was 1 in this group, and non-neurological were 2. So the mortality in CABG now is almost like, it's a surprise if you do it. We do about over 3,000 CABGs a year, and we do, like you noticed here, we will do about 200 simultaneous combined procedures in different combinations. So the follow-up is varied, and like we said, we've already now we are in the 12th year of Medanta, so the follow-up is going on, but it's not enough data right now to present it as a differentiator today, although whatever we have got so far, I just mentioned. So in other words, we had done this study in the early stages of at Escorts, where you would notice here that between January 97 and December 2000, we did all the carotids that we documented, but we didn't have a single stroke in that group. How? There was one before that I learned. There was a lady I had done, she was about 70 some years old, short neck, but very, very sort of calcified plaque, which was adherent to the media, and we really had to struggle to get up on her neck, and that was the lady who I learned a lesson from. And now we have our selective criteria will be if the stenosis is above the jawline with short neck and older ladies, we may not. Now, what has happened now also is that our endovascular, neuroendovascular team has become excellent in doing stenting. So we are more liberal than what Dr. Greco had presented. We are very liberal because we have the confidence. So if we think that the outcome of a carotid endarterectomy is not going to be in the vicinity of 0.5%, then we may stage it even, but we have a hybrid operating room. So we have done combined procedures, hybrid procedures, where the neurointerventionalist will do the stenting and will go ahead and do the bypass right then. So we do it all combined. That's why it has come very handy. We do hybrid coronary surgeries also, like stenting one vessel and bypassing the other or whatever. So all these things have been done. But in conclusion, I would say there's another study we did, the neurologists did, and they also didn't find any major problem with doing it combined. So now the basic concept in our mind is that is this extremely safe procedure if you juxtapose it to the natural incidence of stroke in coronary artery disease. Of course, there is a lot of changes we have made in our approach. We do 98% of our surgeries off pump. So that's not the case in most other countries. In India, at our institution, we've been doing it since '94 when we first, the 4 of us did. There is a gentleman, Antonio Calafiore in Italy, I don't know if you know him, Dr. Greco, But him, Dr. Subramaniam in New York, and Dr. Moore in Germany, on one night we all did a beating heart Lima to LED with a fork. We didn't have stabilizers. We took the two prongs of the fork out of it, and we did it at the same time. So it was night time in India and it was morning time in Germany and USA. It was like, so we staggered. But Antonio Calafiore, if you know him, he's a very good friend also, but an amazing cardiac surgeon from Italy. So anyway, I think that today we can safely say that this is a standard of procedure, and I don't think that there is only controversy that remains is if in your hands it is more than 1%, then you should think about it. Certainly, the recommendation of the International Society for all has been that if your results are better than 3% stroke rate or mortality, then you should do it. But I think the indications are changing in view of the stenting available to us. So we would say if you can do it below 1%, most certainly it's much better to tackle it together than otherwise. Thank you very much.
Thank you so much, Dr. Trehan. Now, shall I invite Dr. Amit Thapa for his presentation?
Good morning, dear chairpersons and friends. A very warm welcome to all the delegates, especially the foreign delegates here. If you have visited once, this is the first time in Nepal, then do make sure to visit many places, and I am sure that you will be bitten by our Nepali bug, which will keep you attracting to this place times and again. Once in is never the move. Well, I will be talking about the use of point-of-care ultrasound and intraoperative neuromonitoring to improve the outcome of carotid endarterectomy. And on behalf of Nepali Society of Neurosurgeons, I would like to extend warmest greetings to all of you. Well, I have nothing commercial related to this presentation. Few of the things which I have been presenting here will be only for the academic exchange. We started this point-of-care ultrasound way back in 2012. The first training was conducted in Kathmandu Medical College, and then we have been since then working on this particular modality times and more. It's good to see that emergency physicians have taken up this in a very great manner, and I am happy to know that most of the centers in Nepal, in particular emergency physicians and the critical care units, have their own dedicated ultrasounds to work on this modality. And we have also come up with various publications on the use of focus, both as for the training reasons as well as in the undergraduate training for the MBBS, because we all know that in MBBS days we hardly have this opportunity to handle one ultrasound probe with us, and this is something which is must to go. Well, focus or the point-of-care ultrasound role in carotid endarterectomy starts with the diagnosis per se, as we have already heard our previous speakers making a comment that the duplex ultrasound is much more better in identifying the stenosis and hotspot to make the idea of or selecting the cases for going into carotid endarterectomy. Now, carotid endarterectomy or removing the plaque is often compared to carotid stenting. But then when we see the results for the long term, we have known that more than 25% patients decrease in mortality has been documented out of CE as compared to the carotid stenting on a longer run. Henceforth, this is something which we always look forward to as a standard procedure. Now, when we talk of a procedure, it looks very straightforward. We identify a case, select select a case, and then do a proximal distal control, open up the artery, remove the plaque, see that there's no intimal tear, just take a controller and do a follow-up scan to see whether everything is all well with the patient, and patients do well in most of the times. But then situations may arise when you have conditions like this one, where this patient had a floating thrombus, and on monitoring we found that the patient do require a shunting process. And the shunting actually puts the patient at risk. This patient turned out to be well and this is healthy and there's no problem. But then there are many cases where the complications have been well reported. The complications can be major, can be minor, and the most important complications do occur with various other risk factors which are available in many patients. Now, we also know that the complication increases with the age. And the complication reported on an average in the literature is almost 6.5%. As we have been hearing Dr. Grego this morning, that the medical treatment has gone beyond decreasing the mortality or the risk of stroke to less than 2%. So our target should be to achieve the perioperative death or stroke to less than 3%, and if in case it's doable to less than even 1%, because that is something our target should be with the changing movement. Now, interestingly, if you see that the complications of carotid endarterectomy are largely avoidable. And when we talk of perioperative strokes, we mean that the strokes which has occurred within 12 hours or within 30 days of surgery. So it can be divided into intraoperative strokes, that is within 12 hours of the surgery, and the major reasons for intraoperative strokes have been hyperperfusion because during the clamping per se, or because of the thrombosis when we are putting a shunt, either from the endarterectomy side or during the intraoperative cross clamping. And that's why there's always a risk of routine clamping, shunting whenever we do, because it can cause a plaque embolization, carotid artery dissections, or inadequate shunt flow or shunt thrombosis per se. And even when we talk of a post-operative stroke that occurs within 30 days of surgery, then it can be because of thromboembolism or because of cerebral hyperperfusion syndrome, also known as CHS. And in these cases, it has been seen that the intraoperative monitoring has played a vital role in avoiding these complications by using the shunt very selectively in the patients. Now, when we talk of cerebral monitoring techniques, it can be to monitor hyperperfusion or to monitor embolism during the surgery, or even cerebral hyperperfusion syndromes. Now, most of the modalities are available to us. Say, for example, sonography is available to us, EEG is available to us. So that's how we can actually monitor these patients. But point to note is no single test is comprehensive enough to detect everything which is going wrong in your patient. Henceforth, we have to use a combination of it. So since last 1.5 decade, we have been using a combination of these technologies in our patients. So to begin with, we did not have too much of hardware. We only have a simple EEG machine and a normal ultrasound machine. So we used an ultrasound probe to first of all locate the plaque and to identify the bifurcation, to identify the area of incision, and then hang it on the patient's temporal bone so as to give a continuous monitoring of the MCA as we are operating on the patient. And similarly, the EEG has been tucked on the patients and to compare both the right and the left side whether the amplitudes are decreasing when we are clamping. So this actually gives us an idea about whether to use a shunt selectively in these patients or not. So this is how we started earlier, and then later on we have actually improvised with a lot of new gadgets which has come up in Nepal. Now, when we talk of the use of POCUS or the point of care ultrasound in carotid endarterectomy, it can be defined either for the preoperative assessment or intraoperative guidance, or even for postoperative assessment to follow up. Now, preoperative assessment is definitely for identifying the characteristics of the plaque and the location, because this can identify the risk involved in the surgery. Intraoperative guidance for the vascular mapping, definitely, and also for identifying, for using it as a TCD machine for proximal MCA and contralateral ACA monitoring. And this picks up microembolic signals during the surgery, so that the patient had a very low risk of the stroke later on, and also to predict those patients who have a cerebral hyperperfusion syndromes. Post-operatively, definitely it is able to identify whether the stenosis has been taken care of well or not, and of course to follow up ultrasound is mandatory when you have a contralateral sitting stenosis which has been managed conservatively till date. Now, a few words about microembolic episodes. This is very important for us to know, because this is an independent predictor of TIA and stroke risk, and it has been frequently seen during deep clamping and stunting, and have been categorized to be either a gaseous embolism or a solid embolism. Now, TCD is the only available intraoperative modality to detect MES, and that's why it should be used in literally all the patients whenever we're using plaque, particularly the ulcerated plaques ones, and of course when we are putting a shunt. So as MES is larger and have different material of the content, it produces a different acoustic impedance which can be picked up by hearing or seeing on this as the signal changes. And it has been found that the MES which is being generated during the dissection as well as during the enclosure has far more significant association with the post-operative stroke and the stroke-related death. And even frequent MES can also be in the immediate post-operative period can be predictive of the post-operative stroke. Of course, it's a surrogate marker to evaluate the effectiveness of the antiplatelet regimen we use in the post-operative period. So this is even being used for carotid artery stenting these days, because this has been shown that when you are employing your embolic protection devices across the plaque, then these microemboli can be generated. That's why they have been using it now in the carotid artery and the carotid stenting procedures also. Now a word about cerebral hypoperfusion syndrome, because this is something which is avoidable, but if in case it occurs, it leads to mortality in almost 40% cases. Now this is because of the postoperative stroke occurring in the symptom-free interval in the immediate post-op patients of the CA, and it has been found to be having an occurrences of 1 to 3%. It produces neurological symptoms along with the doubling of the preoperative cerebral blood flow. So this is how it appears. So in the figure down below, you can see that the velocity has actually, the mean velocity has increased from 45 to 91 after the clamping is removed. So these patients had a very high risk of going into cerebral hyperperfusion syndrome, which is nothing but the augmentation of the cerebral blood flow after the clamping is removed because of the disturbed autoregulation. So whenever you see this thing happening in the patient, the first and the foremost thing should be a very, very strict blood pressure control in the post-operative patient or the post-operative phase. Otherwise, patient may land up with the hemorrhagic stroke, and the mortality in these cases have been found to be as high as 40%. So this is a very important thing to be taken about because of the strict BP control which is required in these patients. Now, regarding IONM or intraoperative neuromonitoring, this is definitely being helpful to identify or localize the neural structures. There are a lot of new structures around the carotid area where we are operating, and also to test the function of these structures when we are operating, and then also to detect intraoperative neural injury while clamping the arteries, as well as by using the stent. So it has been shown that the IONM techniques actually reduces the healthcare cost which has been associated with the strokes in these patients. And IONM per se is not just diagnostic, it's also intervention, because as soon as you see a dip in the EEG or ACCP, you can actually reverse your clamping or produce some hyperperfusion methods by which you can do away with these problems. And as for there are a lot of things that IONM can be used in terms of the carotid endarterectomy surgeries, and the basic modality which we are using in IONM is either EEG, nowadays even BIS, particularly the bilaterally placed BIS is very helpful. The free EMG run is also good, and also SSCP and MEP. Now a word to note is that both the EEG and SSCPs are fairly reversible, and that's why if the patients have a reversible phenomena after going for a hyperperfusion or a reperfusion, then the patient do not end up with the motor deficits. However, MEP, if in cases have dipped more than 50%, then of course the chances of an irreversible damage is very high, and that helps you to prognosticate also in the post-operative period which of the patient will be a reversible deficits or a permanent one. Now we have developed a protocol for each patient, because IONM is something which is very much of an interdisciplinary role. Both the anesthesiologist, the neurophysiologist and the neurosurgeon should know as to what to call at a day and to stop further maneuver to reverse whatever you have done. So this is how we interact with each other, and we have a protocol set in to identify each of these patients where to stop and what to do. Now there has been a recent publication where they have used both the POCUS as well as the IONM in this patient, has found to have a risk of perioperative stroke as well as mortality to less than 1% while they adopt this technique. And they also have found there's a correlation between the POCUS as well as the SSCP and the MEP finding whenever these patients are subject to these types of modality. Now in this you can fairly see this is an EEG run on the top. Whenever the clamping starts, this is a patient with a burst suppression which is occurring on the EEG, and as soon as you increase the blood pressure, the burst suppression reverses back, and then when the declamping is done, the patient attains a normal EEG value. So if you can see all these markers on the screen, you know for yourself what is happening to the patient who is silently under the anesthesia or may not respond to your command because of the sedation drugs. Of course, there are definitely limitations to use of these modality. The first and the foremost is the attitude of the physicians. Once we cross a very high number and are doing very safe surgery, we think that the risk of the surgeries is fairly less, which is not true. One patient has a problem, and then whole of your team starts getting depressed, and a lot of things starts coming up. So that's why we should not, first of all, think that our surgery is safe. Anything can go wrong, so it's better to always put on these monitoring devices on the patients and play safe, so that you have a documented thing in time consuming during a busy schedule. Technical limitations can be there because these are very much operator dependent, and since the operator is supposed to discuss everything, sometimes it becomes very time consuming, and accurate interpretation during that particular hastiness of the time can actually create a negative output. And of course, there's a risk of false negative, particularly when we're using INM and it is under the effect of certain gases anesthesias. So one should be aware of these false negative values also. And then of course the anatomical limitations like a thick temporal window which will not allow the sonographic window for the patients to evaluate, and most of the modalities are of course tedious and requires much more of a training over the period. And this is just not the all. Definitely we must have heard to our previous speakers that there are other measures also be taken to reduce our complications. But to conclude, what we have found in our experience as well as in the literature abroad is that POCUS and the INM enhances the precision and the safety of our surgery by providing a real-time feedback because of which we can make change in the decision as well as keep our patients safe. It not only produces the anatomical information but also helps in surgical planning and execution. And of course, it is an integral part of the patients both in the pre-operative as well as in the intraoperative and carrying on forward in the post-operative follow-up. INM actually helps you to preserve the nerves. There are many nerves around, so that has to be taken care of. And of course, to minimize the neurological complications in the surgery. And we should be using the shunt as selective as possible after finding all these modalities have shown certain red signals onto the patient. Otherwise, do not use the shunt routinely as much as possible. And of course, there's a combination which helps because there's no one single modality which is comprehensive in finding these changes. Thank you for your patience listening.
Congratulations, Dr. Tapa, for the presentation, and then we go ahead with the next presentation, and it is carotid body tumor, single center experience by Dr. Mirko Menegolo from Padua, Italy.
Thank you very much, Dr. Sandeep Pandey, and to all the scientific committee for this very appreciated invitation. It is a privilege for me to be here, and it is also a privilege for me to talk about this very peculiar topic in front of my friend Alberto Muñoz, which has one of the highest casuistics of this disease related to the high altitude in South America. And I suppose also the high altitude of also this place could be a risk factor. May I have my slides, please? Well, carotid body tumor is a very small receptor within the carotid bifurcation belonging to the paragangliar tissue, which is spread over the neck and chest and abdomen, and which is very sensible to the tension of oxygen and dioxide. So in situation of hypoxia, hypercapnia and metabolic acidosis, it's function a lot, and so he can develop carotid body tumor, which is the most frequent tumors among the head and neck paraganglioma. Usually it's a benign tumor. The malignancy is very, very rare, and in a few percentage of cases it belongs to paraganglioma syndrome with a multiple localization. The etiology can be added to the altitude because a situation of hypoxia can stimulate the development of this tumor, like happens in the Andean altitude, maybe here, but however have been discovered many gene modifications that can explain the grow up of this tumor. In fact, many modification of many mitochondrial genes have been identified, especially in our experience, in which we show that we had a lot of patients coming from a very small area of the north of Italy, in which the incidence of carotid body tumor was very high. So we suspected a kind of founder genetical effect, and we decided to perform in all of these patients and in all of their relatives genetic examination, and we discovered that was very, very present a mutation of the subunit D of the succinated dehydrogenase genes. As I said, the carotid body tumors belong to the head and neck paragangliomas that mostly are located on the carotid bifurcation, but sometimes can be located in the tympanic cavity, but also in the jugular vein, in the jugular foramen, or inside the vagal nerve, mostly common as vagal paraganglioma. Our experience included also other paragangliomas, especially like those located in the abdomen. This one in particular that required a complete resection of the aortic bifurcation for a radical resolution of the problem and a prosthetical reconstruction of the aorta. You can see on the bench the cut down of the paraganglioma. Or like this case in which we removed an inferior vena cava secreting paraganglioma, is this, with a cut down on the bench of the paraganglioma. This is a moment that we perform in every operation. Every time we resect a paraganglioma, both of carotid or abdomen on someone else's side, we perform a cut down on the bench in order to see macroscopically if the capsula is completely, fully surrounding the paraganglioma. This is a macroscopic sign that maybe your operation has been radical. The natural history of this disease, unluckily, is very, very poor of symptoms. In fact, the majority of patients discover casually that they have a paraganglioma, and sometimes when this is too much big to be treated. In fact, the worst prognostic factor are the dimension at the time of diagnosis and the presence of symptoms. The most used classification used is an intraoperative one, which is the Chamberlain classification that regards the involvement of carotid axis. So the presence of involvement of the vessels means that maybe we have to reconstruct also the carotid bifurcation. To have a standardized procedure to treat this disease, in 2002 we established a multidisciplinary team in order to have the best treatment and the best diagnostic protocol for this patient. This multidisciplinary team includes vascular surgeon, but also endocrinologist, genetist, interventional radiologist, chest surgeon, and so on. And so every time a diagnosis is done with duplex scan, the patient is studied with a CT and then with an endocrinology screening in order to identify a possible suppression, and with a genetic screening in order to identify that genetical modification that could lead to multiple localization. And in case of this, a total body metabolic scintigraphy is performed in order to identify multiple location or even secreting location. In case of multiple location, it's very important the timing of surgery that usually gives priority to the secreting one. The only contraindication to surgery up to date remains the mainstay treatment of this disease. The only contraindication are the poor general condition of the patient, very poor condition, or high volume of the mass that maybe is over the cranial basis and the metastatic diffusion. As I told before, surgery remains the mainstay treatment, especially if associated to adjunctive procedure like endovascular procedure, in order to reduce the vascularization of this tumor, because the main problem of this surgery is the high vascularization of this tumor. So if we are able to reduce the intraoperative vascularization, we can achieve better results. Radiotherapy, it's an option that can be reserved only in those patients which are unsuitable for surgery. As I told, surgery can gives radical treatment with excellent long and term results, low risk of stroke. The disadvantages are mainly related to blood loss and, of course, because of possible cranial nerve or arterial injury. In our division, the protocol of treatment has electroencephalography monitoring for all the patients with a Pruitt and Hara shunt always available. This is only in case we need to reconstruct the carotid bifurcation. Sometimes it happens. A system of collecting the blood loss to reperfuse the patient is always present. From 2000 3, we started in the bigger carotid body tumor a preoperative embolization in order to have low blood loss during operation. We started embolizing with coils. We had a few experience with devascularization of external carotid artery with the covered stents in order to exclude the feeding vessels. Nowadays we use a transfemoral approach with microsphere or contour polyvinyl particles to embolize inside the glomus. We abandoned totally we did few cases with a transcervical puncture of the glomus with glue. This was, in our experience, was not good because the inflammatory reaction of the glomus made very difficult the dissection of the glomus from the vessels. These are some examples of embolization and the subsequent surgical excision, which usually do not, it's quite very poor of blood loss. And you can see in this picture how it can be identified easily the cranial nerve and be respectful of those with a complete resection of the carotid glomus. Again, the cut down on the bench of the glomus. This was one of the biggest we treated, not the biggest one, but one of those, in which, as you can see, before and after the embolization, the dimension of the tumor was really reduced, and so the surgery was easier. Another case of this very, very huge tumor, in which we perform both embolization and also exclusion of the feeding vessels with covered stents in the external carotid artery. We obtain a reduction of the mass with a little easier excision, surgical excision of the tumor. This was a small collateral effect that this woman had temporarily because of the high dosage of radiation during the long endovascular procedure was the cause of this transitory alopecia. But as you can see, the dimension before and after the embolization and also the vascularization was reduced thanks to the endovascular procedure. This case is just to emphasize that the radicality of surgery is very, very important. This was a patient that was elsewhere treated many times for a tumor of the sympathetic change. No previous operation was radical. In fact, the patient had a lot of recurrency. And as you can see by the scar he had, he was treated many times in different centers in order to be radical also with the recurrency. We had another lateral cervical very low approach that allows us to reach the anonymous artery bifurcation, you see, and to carefully remove all this tumor that was belonging to the sympathetic change in order to have a radicality removal, as you can see. This is another nice case in which we're supposed to have a carotid body tumor associated with a coiling of the internal carotid artery. That instead, we discover intraoperatively that it was a saccular aneurysm. So we remove the carotid body tumor at the same time we reconstruct the internal carotid artery with an end-to-end anastomosis with the resection of the aneurysm. In 2019, we published this paper in which we compare the casuistic before and after the institution of the multidisciplinary team that showed that the results were significantly better after the institution of the multidisciplinary team in terms of local complication, in terms of cranial nerve complication, and also in terms of blood loss. Our update experience since 2023 is about of 88 patients, 76 carotid body tumor and 2 vagal tumors, 13 without preoperative embolization, 63 with preoperative embolization. Well, in conclusion, based on the natural history of the disease, all carotid body tumors should be considered for treatment. Even the smaller, maybe up to 2 centimeters, can be followed up every 6 months with ecography, but more or less all of them are candidated to be treated. The choice of the most appropriate treatment is based on the morphological features of the neoplasm, localization, size, and vascularity. degree of involvement of the carotid axis, extensions involving of the carotid foramen. Surgical treatment remains the gold standard. The lack of radicality of surgical exercise is certain condition of recurrency. The follow-up, conducted on an annual basis, must include an ultrasound and a duplex scan, both of the operated side but also of the contralateral side. Carotid body tumors represent a complex pathology that requires the collaboration of multiple specialists for an optimization of their results. Multidisciplinary team approach and preoperative genetic evaluation is mandatory in familial form for early and complete diagnosis, correct and surgical management of carotid body tumors. In case of subunity SDH mutation, a close follow-up is indispensable for the improvement of early and long-term results in head and neck paraganglioma surgery. Thank you very much.
Congratulations, Dr. Comenigola. Very nice presentation, very interesting topics you have.
Thank you.
I think maybe in the question and comment we could have a conversation about a carotid body tumor here in the Himalayas, because as you said, in South America and Central America, because of Andes we see it more, and as you showed also in Italy, in the northern part, there are places probably more genetic, so it will be very interesting
to I think so.
Have a discussion. Thank you very much.
Thank you very much.
So now, to continue, we will have CA versus CAS. Where do we stand today? By Dr. Sriram Narayanan from Singapore. So, sorry, we go with Dr. Barry Betty. Stroke prevention during a carotid procedure by Dr. Belli.
Thank you, Alberto. And I think it's been a wonderful session so far. And I really compliment all the speakers for some wonderful talks, I think, by Dr. Greco, Dr. Naresh Trehan, and then, of course, the last one from carotid body tumors. Can I have a presentation, please? So I think a lot of, So when you look at the treatment for stroke prevention, a lot of this has been covered up right now. So I'll skip to certain slides. The techniques of stroke prevention, of course, as you know, one is, of course, the conventional endarterectomy, diversion endarterectomy again, which has been discussed upon, and then the third one that we've started doing for the last about 8 years or so, which is the modified diversion endarterectomy, and then, of course, you have the carotid stenting. Well, in CEA, but when you look at the treatment for CEA, the arteriotomy extends from CCA to the distal endpoint of the plaque, and this requires a long arteriotomy, and in subsequent closure is required with a patch. Well, in diversion technique, of course, you transect the internal carotid artery at the bifurcation, and then you remove the plaque, invert the artery and remove the plaque, and then, of course, you reconstruct the artery after that. Now, what is the modified diversion endarterectomy or modified diversion carotid endarterectomy? This is a hybrid technique which is a midway approach to carotid endarterectomy and diversion endarterectomy. The arteriotomy extends from the CCA and extends just proximal to the carotid bulb. That is the dilated part of the artery which is there. And the arteriotomy length is generally required for a maximum length of over 2 centimeters, as you can see in these pictures out here. And following the arteriotomy, the circumferential plaque from the CCA side is lifted up and divided proximally. The plaque is lifted up, dissected. You basically crush the external carotid artery so that you get the plaque out from the external carotid artery. And then after that, you keep on pulling down, you're tugging the ICA caudally, which causes the ICA to get inverted. And this is the technique of, as you can see out here, the artery is being inverted out here, and we do this particular procedure. The slide is not moving. Yeah, okay. So this is a video for the sake of brevity of time. I will skip this video of modified diversion endarterectomy because we are going to discuss about the stroke prevention procedures right now. Well, our technique has been a little different out here. Of course, Dr. Amit Thapa also discussed a lot of techniques of monitoring. But what we do generally in all our cases nowadays is to use a cervical block instead of general anesthesia in almost all our cases, unless and until the patient is uncooperative or there is some other reason the patient is on dual antiplatelets and all, then of course we prefer to give general anesthesia. But otherwise what we do is continuous neurological monitoring with verbal cues, as I'll show a video also. With this we have been able to reduce the average cross-clamp time for carotid from 7 to 14 minutes with selective shunting strategy. We don't shunt electively. In fact, earlier I never used to shunt, and now we become selective shunters after we started doing them under regional analgesia. And to look at this, of course, it's a little old statistics out here, but about 243 odd patients that we operated in Gangaram out here. And in Hami Hospital, where we were doing exclusively eversion endarterectomy, then I switched over to modified eversion endarterectomy, and then we switched further again into general anesthesia, from general to regional analgesia. And as you can see from this particular thing, that 94% of the patients we have subjected them to modified eversion endarterectomy, and 4% patients we converted them, because when we found the plaque was extending beyond, and sometimes it's difficult to get the plaque completely feathered off, then in that case probably it's a good idea, and this is the major advantage of modified eversion endarterectomy, that allows you the flexibility of using a patch if required. So this is what the thing is. And generally the complications, we had one patient who had a transient monoplegia, but beyond that there was nothing. Vagus of course is sometimes a problem, because what happens is when the anesthesiologist is giving a block out there at that particular time, so transiently the patient may have hoarseness of voice which basically lasts for a week or so sometimes, but otherwise no major complications and all after the surgery. Well, when you look at the conventional technique which is most frequently employed, it's generally the surgeon's preference. It's a longer clamp time which is there, technically demanding. The patch or shunt is definitely required in all the patients, and shunt is required in quite a few of them, because especially if the patching is going to take time, then you need a shunt, a long arteriotomy. And sometimes the closure of the most distal part of the ICA may be at the limit of the surgical field, because you have a hypoglossal nerve coming up out there, and sometimes it can limit your dissection. And the second thing which was again described by one of the speakers earlier is that when you're pushing in a shunt inside, when a patient is desaturating or something of the sort, or your evoke potentials are showing something, you put in a shunt and then you can traumatize the artery distally, and that can be a problem. So there are certain areas which are worth discussing, but one is the people who are routine shunting types versus the selective shunting versus no shunting, and grey area. And I did heard from one of the chairpersons out here about not using any shunt. I was in that category a few years back. But some evidence that routine shunting in setting of severe cerebral ischemia decreases the stroke rates and ischemia reperfusion. Of course, that is also there. But again, like I mentioned, that routine shunting can cause intimal injury, and sequelae during insertion of the shunt, embolization, pseudoaneurysms, and all those kind of things. When you look at the long-term data, there's nothing, no randomized controlled trials are really, giving us any conclusion that this is better or that is better. So ultimately, I guess it is to the surgeon's preference. But this very interesting paper came from Abu Rahma, which was in shunting during carotid endarterectomy. And when you look at the carotids which were performed with routine shunting, selective shunting, when you look at the perioperative stroke rate, perioperative death, there's no difference at all. So it doesn't really make a difference whether you put in a shunt or whether you do selective shunting or routine shunting. Well, when you look at selective shunting, the determinants are intraoperative measurement of the carotid sum pressure, which we discussed earlier, and all that sort of thing. I used to do that maybe about 3 decades back, but I think we stopped doing that now. Intraoperative monitoring of the EEG, again, one thing. Evoke potential, this is something which I saw in Germany very regularly. It was being done out there. And the measurement of MCA flow, we did this also. We used transcranial Doppler again, but we found that because of the patient mobility, the patient moves a little bit, the transcranial Doppler can lead you haywire, picking up a lot of hits which are probably not happening out there. And monitoring the cerebral oximetry. Well, for regional or local analgesia, determinants are the shunt insertion if symptoms develop after the carotid artery is clamped. If you see that the patient is desaturating while you're opening up the carotid, you put in a shunt at that particular time, and generally if you do it in a controlled manner, it's generally not a problem. And if you're getting to the end of the plaque, then we wait for a minute or two, and then insert the shunt after taking out the plaque rather than pushing it through the plaque, because that can again be catastrophic at times. Sorry. So this is just to show you our video out here. If we can play that video, please. What we do real time. Yeah. So this is our anesthesia person who's standing at the head end, and he's asking the patient while we are operating, he's telling them to hold the hand, loosen the hand, hold the hand, loosen the hand, and you will hear his voice in the background. And this is what is happening out here, that we keep this part of the patient exposed out here, and while we are doing this, the verbal cues are on all through the procedure while we are operating. So like in this particular patient, we did require to put in a shunt. We put in a shunt, and immediately once you put in a shunt, within about 30 seconds or so, the patient recovered and all, and after that we were able to. So we did publish a paper on this also in 2016. And to look at the techniques which are there, modified diversion endarterectomy, as I said, it's a good hybridization of CE and EA with comparable long-term results with a much shorter cross climate procedure time. Our early experience with this technique both under GA as well as RA as well as selective shunting has worked well without complications, and we've been performing EA since 1998 and modified diversion endarterectomy since 2013, and that's almost about 10 years. And this appears to be equally good, if not a better option. To conclude, stroke prevention techniques are ideal for patients who have symptomatic TIA or stroke. Early detection and proper evaluation is the keystone for further management of the patient. The choice of treatment has to be tailor-made as per the patient and not as per the competence of the operating surgeon or the interventionist, because many a times we are now led by the industry and all to do more and more stentings and all. So I think we should choose, and I do have an anecdote to relate. I had a patient who was about 84, 85 years young brigadier who once came to me, and I told him, I said, maybe we can put in a stent in your case. He said, no, the average lifespan in my family is 100 years. I want to get operated. We operated until every year he sent me Happy New Year messages and all kinds of messages, and this is about 12 years down the line. So he's closing the 100 right now and still very active. So that it has to be tailor-made as per the patient. And 90% of the patients will fit into the criteria of carotid endarterectomy, which still continues to be the gold standard, with long patency results and better efficacy. I bring warm greetings from my team at Sir Gangaram Hospital. Thank you very much for the opportunity.
Thank you very much. Great presentation. One comment and question I would say is when the distal plaque cannot be removed because of it's too high, then one of the technique that I use is to tack it and then suture that plaque into the carotid so that it will not become a...
So that's why either if it's a very high lesion out there, in that case you tack the suture, of course, that's the standard approach. Sometimes, of course, what you need to do is mobilize the hypoglossal nerve, because if you see the hypoglossal nerve sometimes gets tethered with an artery and a vein. So if you're able to basically, disconnect the artery and the vein, you ligate the artery and the vein, you're able to pull out the hypoglossal nerve a little bit, caudate. And then after that, you can get a proximal end of the artery. Clearly, you can visualize that artery also. Sometimes, of course, you can do a mandibular swing in certain patients, but it's not really required most of the time. But yes, wherever you feel that the plaque is not removed, then you leave that part and tack it down with a proline suture. Absolutely right. Thank you very much. Sure.
So we continue our program, and is Dr. Sriram Narayana. You already presented it? No. So we continue with evolution of stroke intervention in Nepal by Dr. Savas Riyal from Nepal.
Thank you, Chairperson.
Thank you, Imbas and Dr. Sandeep Raj Pandey, for letting me be part of this amazing group of expertise. We all know with the publication of multiple positive trials in the year 2015 and 16, there has been revolution in the treatment of stroke intervention through mechanical thrombectomy, significantly improving the burden of stroke in the developed world. However, currently the burden of stroke is shifting from developed world to the developing world. So today, representing developing world, I would like to talk about the evolution of stroke intervention in my country with my journey from fluoroscopic to gold standard biplane cath lab. Any stroke intervention presentation will be incomplete without showing the slide of mechanical thrombectomy mantra. After the occlusion of one of the larger artery of the brain, in the ischemic zone, there will be two zones of ischemia. The central irreversible zone, we call it core, and surrounding it will be the large reversible zone of ischemia, which we call it penumbra. The formation of penumbra is, after the occlusion, there will be invasion and dilatation of the surrounding pile arteries into the zone of ischemia, which will try to maintain the cerebral blood flow, and the tissue remains viable for several hours. And if we do timely intervention, then we can save the brain from irreversible damage. But if we don't do timely intervention, then in every minute there will be loss of 1.9 million neurons, and the core will enlarges and reaches up to the size of penumbra. At this stage, even if we open the occluded artery, we cannot save the brain. So the mantra for mechanical thrombectomy is time. The sooner the clot is removed, the better will be the outcome. This is the first message we all need to know. Now let's have a macro view of Nepal. Nepal is a small country located in southern part of Asia, in the Himalayan, bordered to north by China and to south, east and west by India. With total area of approximately 150 square kilometer, Nepal has population of around 30 million, where vast cultural diversity exists. Here the shaded part of the map is the capital city, Kathmandu of Nepal, where I started mechanical thrombectomy for the first time in country in March 2019. Talking about the stroke intervention scenario of Nepal, currently still like a tough road to travel. We are only being able to treat the patient from within capital city with very minimal outside reach. So why are we having this lack of reach? There are various factors apart from awareness, lack of awareness of stroke among the general public and even to the healthcare workers. The other factors that contributes includes geographical factors, which includes frequent landslide, inadequate ambulance services, mainly in the rural areas, lack of well-equipped hospitals, and the cost of neurointervention procedure are quite expensive in Nepal, maybe because of inadequate health insurance policy and high cost of intervention materials, lack of comprehensive stroke care centers, lack of expertise. Despite of all these obstacles on our way over the span of few years, we have been managed to treat significant number of patients. Let me walk you through the brighter side. One of the first cases referred to me was a young lady, prior history of rheumatic heart disease. The onset of symptom was 3.5 hours. Her initial NIHS was 19. In MRI, there was involvement of the dominant occlusion of dominant left side MCA, and in MRI, there was involvement of the corona radiata. So if we count the aspect, its aspect is coming around 9. As per the imaging, we all know it's a typical case for mechanical thrombectomy. At that time, even though we had only CM fluoroscopic machine, we proceeded our case in the same machine. We had no other choice, though it was stopped due to lack of software. But fortunately, the procedure went well. This is the post-thrombectomy angiogram, where you can see there is complete recanalization of the previously occluded MCN branches, and this is the clot that we have taken out. And following the procedure, the patient was able to walk, talk, and the patient was discharged with 0 NIHS without neurodeficit. Now we have come a long way, and finally, I'm glad to say today we have state-of-art dedicated for neurointervention, biplane cath lab. This is our stroke workflow. After the patient arrives in emergency, within window period of 6 hours, we image the extent of parenchymal damage. We see by MRI, DW aspect. If the aspect is less than 5, then the patient is not eligible for mechanical thrombectomy. If it's more than 5 with large artery occlusion, and within window period of 4.5 hours, we do bridging thrombolysis.
And if window period of 4.5 to 6 hours, we do direct mechanical thrombectomy. If wake-up stroke are more than 6 hours up to 24 hours, we do in addition DWI clinical mismatch, as in the DAWN trials, which helps us in making decision on endovascular management. As we all know, there are variations among the patient which makes it difficult for us to choose between the techniques. Still, with limited experience, I have my own hardware selection according to the site of occlusion. If the occlusion is ICA terminus or T occlusion, I prefer using large bore aspiration catheter. If the occlusion is proximal M1, again I use large bore aspiration catheter. If the occlusion is the distal M1 MC, I found that with the use of large bore aspiration catheter, the clot tends to migrate distally, maybe because like bifurcation and more curved nature of M2. Hence, I prefer both large aspiration, large bore aspiration and stent retrieval, that we call Solombra technique in distal M1 occlusion. If the occlusion is proximal M2, I prefer stent retrieval only. Now let me show you some of my interesting cases. Case 1, 55-year-old male patient presented with left-sided hemiplegia within window period of 4 hours. And initial NIHS was 13. In DWI MRI, we can see there is occlusion of the right side MCN branches. In MRI, there is only involvement of the insular cortex. So this is again indicated case for mechanical thrombectomy. We shifted the patient to cath lab. These are the pre-thrombectomy angiogram where you can see there is occlusion of the distal M1 MCA with non-visualization of distal branch. As the involvement is of distal M1 MCA, we use Solombra technique, both the large bore aspiration catheter and stent retrieval. And this was the final round where you can see there is complete recanalization of the occluded MCN branches. And this is the clot that we have taken out. This is another important slide of my presentation. The important point I am trying to make here is at 9:15 the patient was at emergency, and by 10:35 the patient was completely recanalized. The due to recanalization time was 80 minutes, and this is very important part of the procedure. We all know time is rent, so we got to get in as soon as we can. So this is the second message we all need to know, like try and get the patient into cath lab as soon as we can and recanalize as soon as we can. 24-hour follow-up CT, we can see there is no extension of the infarct, and the patient was discharged with 0 NIHS without neurodeficit. Another interesting case, 45-year-old female presented within 1 hour in an unconscious state. This is the DWI MRI where you can see there is involvement of both sides basal ganglia, and in MRI we can see there is non-visualization of both MCN branches. So this is the case of bilateral large artery stroke, which is very rare, less than 1% occurrence in literature. We quickly shift the patient to cath lab, did thrombectomy of dominant hemisphere, and in the first pass we could take out the clot, and finally, like this is the post-thrombectomy angiogram where you can see there is complete recanalization of the left MCN branches, and we quickly navigate the right side. We can see there is occlusion of the ICA and MCA, and again in first pass we took out the clot of right side as well. So finally there is recanalization of both MCN branches. And this is the 24-hour follow-up CT. There is resolution of the DWI changes seen in the MRI, and the patient was happily discharged with 0 NIHS without neurodeficit. This is the last case of my presentation. This slide shows our journey of extension of our services to the periphery of the country for the benefit of our country people. The patient was heli rescued to our hospital within 5 hours, and the pre-thrombectomy image showed there is occlusion of the dominant left M1 MCA. We did aspiration technique and took out the clot, and the patient was happily discharged with 0 NIHS. If we see our case journey till now, we are able to do more than 200 cases of mechanical thrombectomy from March 2019, and we are able to achieve complete recanalization in 90% of cases and good clinical outcome in 75% of our cases. And all this success is possible because of our teamwork. It's not just a device. The important aspect is getting the patient, getting access and removing the clot as quickly as possible. That's why it's a team effort, not just neurointerventionist or technology. This is our publication about endovascular management of ischemic stroke in Nepal during our initial 1 year. Here we mention all details about our procedure. Considering the high demand of skilled personnel in our field, our vision is to make this procedure accessible to other centers across the country, make it reachable to as many citizens as possible in near future. To make this possible, we have established recently a Nepal Neurointervention Foundation with motto of improving stroke care by conducting a training program, public awareness program, workshop, thereby making these facilities accessible for all. with this note, I would like to conclude my presentation and thank Himba's team for providing me this platform to show our small effort in developing neurointervention in Nepal. Thank you.
Thank you, Dr. Subhash, for your wonderful presentation. And
thank you, sir.
I'm a big fan of your way of presenting. It's always so nice. Thank you very much.
Thank you.
And please keep up the good work. Now we'll move on to the next speaker, and our next speaker is Andrea Spiritino from Italy, and he's going to talk about bilateral carotid disease, stenosis, prevalence, risk factor, and clinical effect.
Good morning, everybody, and thank you again for welcoming me here, for inviting me. Thank you, Sandeep, and all the local organizing committee. So I'll present you one of our latest work that we published last year in the Journal of Vascular Surgery, and it wants to address the issue of the relation between cardiac disease and carotid artery disease from another point of view that we saw before. So we well know that atherosclerosis is a systemic disease, and of course there's a relationship between carotid artery disease, cardiac artery disease and carotid disease that are well known and well described. And we know that there's an average of 10% of patients with coronary artery disease that presents also carotid stenosis. And so the management of this patient has already been studied, and there are different options where the patient can consider to go with a contemporary intervention, cardiac and carotid, or to have a staged approach. But the relationship is also in a reverse. So we're talking about our patient that comes to our attention for a carotid artery disease, and what's the risk of cardiac artery disease in these patients. So in particular, we wanted to focus on the patient with a bilateral carotid artery disease with more than 70% of stenosis, and those has a higher risk of having cardiac artery disease, and the concomitant presence of those diseases can improve the risk for TIA, stroke, and myocardial infarction. But the prevalence and the really clinical impact of this relation is not so clearly defined. So we wanted to design a study which objective where they want to describe the prevalence, the severity, and the clinical impact of cardiac artery disease among those patients with a bilateral carotid artery stenosis, and to identify those baseline characteristics that may be associated with cardiac artery disease. So we conducted a single-center retrospective cohort study from over an 8-year period. We found 167 consecutive patients that came to our attention with a bilateral carotid artery disease, and we addressed them to a systematic coronarography. And our endpoint were the ones to see the cumulative incidence of stroke and myocardial infarction, and rather the cardiac and the bilateral carotid artery intervention, and also have a look on the long-term survival and freedom for cardiovascular mortality. And the cardiac artery disease that we found were classified in these different groups, the mild and moderate, when we could detect a disease that involved one or more coronary arteries but with less than 50% of stenosis, or if it was the left main disease. Otherwise, if it was a non-left main stenosis, we consider a cutoff of 70%. Otherwise, an angiographic stenosis of more than 50% of the left main was considered severe, while a higher stenosis than 70% on non-left main cardiac artery disease were considered as severe. And those were divided in treatable and untreatable for this kind of diseases. So these are our results where we can find that 1/3 of the patients that came to our attention, so 167, had a severe CAD. So 2/3 of those presented severe CAD in this group of patients, and of course the significant demographic characteristics were hypertension and dyslipidemia, and also having a prior cardiac intervention was found to be a significant feature of this patient. But we did a logistical regression to see what were the predictors of severe CAD, and we found that having a reduced ejection fraction under 30% was a predictor one, and also having a prior coronary intervention. So what's our management for this kind of patient that comes to our attention? So if we can see that the patient with non-severe cardiac artery disease went to staged bilateral carotid endarterectomy, and that's the standard approach. For those with severe CAD, we divided them in untreatable one and treatable. The untreatable one went either to bilateral CAS staged or a bilateral CA staged, preferably for CAS due to the fragile subset of this patient. Otherwise, if it's not technically feasible, we went to carotid endarterectomy. For the treatable patient with cardiac artery disease, some of those, most of them, went to firstly a PCI to correct their cardiac disease, and afterwards they went to staged bilateral carotid endarterectomy. Otherwise, we went to a combined approach with cardiac surgery and the carotid artery surgery. So these are our results where we find that the prediction for a poorer outcome were having a 3-vessel coronary artery disease and of course an untreatable cardiac artery disease. And also we saw the long-term survival for this patient that was very poor for those kind of patients that couldn't benefit from treating their cardiac disease and also having an NIH. So in conclusion, we can say out of this experience that severe CAD is a frequent condition in those patients presenting with a bilateral carotid artery disease and can be detected in 2/3 of those cases. And the reduced ejection fraction and the prior intervention, cardiac intervention, is a predictor of this disease. And but interestingly, those patients that were found to have a cardiac artery disease that benefit from a treatment had a comparable outcome than those patients that didn't have any cardiac issue. And differently, though, the patient with an untreatable cardiac artery disease have a higher risk of post-operative myocardial infarction or stroke. So this poses the question of what's the real benefit of treating those patients with a bilateral carotid artery disease with an untreatable cardiac artery disease. So thank you very much for your attention.
Thank you very much, Professor. Now, I'm told that this is the last lecture by Dr. Thomas Holzevi from Austria, and he's talking about should we treat asymptomatic carotid artery stenosis, a very important topic.
Mr. Chairman, ladies and gentlemen, thank you very much for the invitation, and our chairman of the meeting is not here. Should we treat asymptomatic carotid stenosis? You all are aware of this very important landmark paper published in 1954 in Lancet, the first carotid reconstruction, and that was at that time symptomatic patient with hemiplegia. All the evidence for treatment of the carotid stenosis has been created by surgeons, not by interventional radiologists. So the transfer of these data to other modalities of treatment is questionable. And it took about 37 years to prove the surgery for symptomatic stenosis is worthwhile doing, and another 13 years to prove it for asymptomatic disease. These are the landmark papers for asymptomatic carotid stenosis. And you're still waiting for a randomized trial of carotid stent versus best medical management. It's not out there. All the data the stent people are referring to are surgical data. That's not correct, to my opinion. So the indication for an intervention in the carotid system is prevention of embolic event, not ischemia, and no imaging modality of the circle of Willis, of the arteries in the brain whatsoever. It's only embolic disease from the carotid bifurcation. And this is the lesion we are treating, a high-grade stenosis with a soft thrombus causing emboli to the brain. When do we talk about an asymptomatic stenosis? There are different guidelines, whether you're coming from Europe or across the Atlantic. For the European guidelines, we use a 70% stenosis as a cutoff point and a life expectancy in males of more than 5 years. There's less hard evidence for intervention in women. And there is a little bit of more liberal indication in certain conditions like contralateral occlusion, rapid progression, which is about 15% of stenosis per annum, and before major procedures causing cardiovascular disturbances like CABG and valve procedures, hepatic surgery, and so on. The current guidelines in Europe are asymptomatic, and if you're less than 75 years old, a 70 to 99% stenosis. And you should have life expectancy of at least 5 years. For the US American guidelines, which are much more liberal, is asymptomatic without comorbidities, and the life expectancy and other factors should be done in consideration, which is much more liberal than the European guidelines. With regard to plaque morphology, calcified plaques usually are best treated with aversion endarterectomy. Soft plaques can be done with either conventional endarterectomy and patch, and they're a little bit better for stent. Long lesions beyond the crossing of the hypoglossal nerve, or reduced stenosis are usually better treated by a stent, but they can be treated safely with surgery, as I will show you tomorrow. How's about anesthesiologic management? There's a lot of debate across the world which anesthesiologic management is preferred, either local anesthesia or general anesthesia. Actually, it's a matter of preference of the surgeon and the patient. You have to discuss this with the patient because local anesthesia can be quite cumbersome if the patient does not comply with the requirements. If he's nervous or he gets panic underneath the curtain, then surgery is extremely difficult. But if you explain why you're doing the procedures under local anesthesia, usually it goes well. With general anesthesia, it's easy. You have a stable field, you can do everything, you can harvest the vein wherever you like, whatsoever you can do, but you don't have knowledge about what's going on in the brain. There's absolutely no information. You can do whatever you want to do. You can use cerebral oximetry, you can use EEG, ECG, whatever you want to do. You don't know what's going on in the brain, only with local anesthesia. And there is the Gallo trial, which has been published in the Lancet in 2008. There is absolutely no difference, with a slight disadvantage with regard to cardiac events in the local anesthesia group. So, to date, for example, me, I'm preferring carotid endarterectomy local anesthesia. I just do it in general if the patient cannot move his hand or if the patient doesn't speak my language, which is sometimes the case, especially if I'm doing surgery abroad. And the typical procedure is aversion endarterectomy because that can be done easily in local anesthesia. You don't need to harvest the patch somewhere, or you don't need to harvest the jugular vein for a patch, so that's straightforward, and it's usually a procedure which lasts no longer than 30 minutes. Intraoperative angiogram is mandatory. We do ACC puncture, and we do use in two fields, mainly not so much to show technical proficiency of the procedure, but you occasionally can find other things, like in this case, an aneurysm in the medial cerebral artery, which was unknown before to the patients. Why is it unknown? We mainly rely in our country to duplex, and we don't do any imaging with angiogram or CTA or MRA. The results in men, you will get an advantage after 1 year because you have to account for the intraoperative morbidity and mortality, and it's significant and stays significant for the rest of the follow-up. It's not so significant in women, and this is the data of the long-term follow-up of the ACST1 trial. So my surgical conclusion is I have a very strict indication for any intervention of the neck arteries. A multidisciplinary approach is helpful. You can take the angiologist, neurologist, neurointerventionalist together into the team to decide when to intervene on the patient and what kind of intervention you're giving to the patient. Of course, it's very important to pay attention to long-term management also of non-vascular diseases of the patient. Patients with vascular disease often have different other conditions, especially in the larynx or other tobacco-associated conditions or with diabetes associated, so you have to take that into consideration. I think on the long term, both intervention approaches, the endovascular and the open, will have their place in the future, but it has to be a team who decides which intervention should be performed for which pathology. So the answer of the given question, should you do surgery in asymptomatic patients, is yes, in men, for most of the cases. Maybe for women, you have to be much more careful in women, but always have a very strict indication, and obey current guidelines. It's mainly for legal reason. If something happens, and there can be something happening, and you can cause a stroke with coronary surgery, so stay to the guidelines, stick to them, then nothing will happen in court later on. And a good hint is, in Austria or in Europe, if you want to take part in a multinational trial for asymptomatic disease, you should prove that you and your team can do the procedure with less than 1% mortality and less than 3% morbidity. That's a good benchmark where to perform the procedure in your department. Thank you very much indeed.
Thank you, Dr. Hosbin. So now we open the discussion. Is there any question of the auditorium? Yes.
Yes. I would like to ask a question to
Thank you. Very enjoyable session. I would like to ask a question to Dr. Mirko Menegolo on the management of the carotid body tumor. I wonder, for carotid body tumor, if the lesion is very high, what would be your advice on the management for distal control? Do you have to involve the maxillary facial surgeons, or do you have to involve the neurosurgeons as well? Because our problem sometimes is that the distal control is very difficult to control, and we may have to involve other subspecialists. Thank you, Marco.
I'm really sorry. I have to ask you to repeat the question because I was downstairs for another presentation, so I just came inside.
Yes, yeah. I'm so sorry. I'm Yu Chi Chan.
No, sorry,
Hong Kong. I enjoy your talk very much. I just want to ask you, what is the advice you give if the carotid body tumor extends very high up and very distally? How would you advise us for the gain of distal control?
It depends. Okay, for this reason, a CT scan before intervention is mandatory. One of the limits we have in terms of dimension is the styloid process. When the mass is over that limit, it could be a very difficult or contraindicated approach. Once the mass reaches the skull base, it's very difficult to remove, and so probably is one of the cases that could be candidated to embolization and radiotherapy.
Thank you.
I would like to ask about the carotid body tumor in the Himalayas. I've seen the papers mainly from Tibet, near China, a lot of numbers, but I'm not aware about papers from Nepal. I would like to know about it.
Well, we have operated on few cases of carotid body tumor, but most of them are asymptomatic and because of lack of much investigations, so they are not coming to us. But only when they are symptomatic, then they are coming, and we have only operated on maybe 10 cases in my career. That's about 45 years, 10 cases. Yeah, Dr. Uttam.
Yeah, thank you. Maybe our center is the center who is operating more carotid body cases. So far we have done around 75 cases in our center, around 14 years time. And I don't know, on one case we had to leave. We operated, we incised, then we thought that this is operated, very hard mass and engulfing anything. So we opted for closing the wound. It's like that. Sometimes we use some, it's the carotid body tumor. Nowadays, after operating for so many carotid body, nowadays we think that it's easy work. But to my colleagues, most of them, they come with for histopathology. It is contraindicated. Most of the time, they puncture with the needle for the aspiration, and this is blood money. So we have to know that for the carotid body tumor, so do not aspirate for the fine needle aspiration. So our result is quite good. We have published 2 papers in the carotid body tumor.
So what do you think? Is it more? Do you think there is a lot of cases?
No, it's our center is the referral center. Our center is the vascular center, so most of the people, they come to us for the
You have 30 million people in Nepal, and you say you had 75 cases in how many years? 40?
Yeah, 40 million.
14.
40.
So in Bogota, Colombia, I think we have an epidemic of carotid body tumors because we do much more than carotid artery disease. So now, thanks to the advice of our friends from Padua, we are starting to do genetic testing in our country. Probably we have the altitude
and also the genetic mutation.
As you said, it's very interesting in north of Italy. Is that in the Alps region? Is high or?
It's medium high, about 800 meters, which is the Valle dei Mocchini.
Yes, 1,000 meters.
1,000 meters. It is a small country village, 8,000 meters on the sea level, so it's not so high. It's not an hypoxia problem. But the doubts came out because we had a lot of people came into Padua because of a carotid body tumor living in the same country village. So it looked a little bit strange. So in cooperation with our colleagues from genetics, we say, well, try to do a genetic investigation. And we found a mutation in the patient. So we extend the examination on their relatives, and we found that many of them had this genetic mutation. So we performed duplex scan in all these people, and we found a lot of carotid body tumors. So this developed the creation of this multidisciplinary group, and also the basis of a genetic analysis that allowed us to discover a lot of carotid body tumors of our casuistic. and maybe to follow up them strictly and to treat them maybe when the diameter is higher than 2 centimeters, more or less. I don't know if in literature there is a minimum size to operate the. What's your policy, Alberto, regarding the dimension? Do you treat the smallest one also, or only the biggest one?
We usually, is that the high altitude carotid body tumor, we think is different from the non-altitude.
Yeah.
So malignancy is even more rare.
Yeah.
So patients with tumors less than 2 centimeters, we follow up. And
like us.
So we have had a series of 30 patients followed for 5 years, and we saw that only 3 patients needed an operation. So if they go above 2, we operate. If they stay stable, we don't, just follow.
Yes, like it is the same of us.
Yeah. Alberto, how about bilateral? How often do you see bilateral carotid body tumors? Because again, that's something that we see quite commonly also. Probably in our situation, we see about 10 to 15% of patients coming bilateral. What is your, and I think from Padua also, what is the incidence of bilateral carotid body tumor? Because you always pick up something out there.
For us, in a prevalent study that we did, it is 10%. I don't know in Padua.
For us, it's 5 to 10%.
If I can just, yeah, go ahead, please.
Probably it's more when there is a genetic component that is bilateral.
So I think just a couple of points. One is, of course, that regarding embolization, somehow our experience hasn't been all that great unless and until they're really huge and you want to embolize them. Because you really lose your tissue planes completely, and then you have a lot of bleeding, because if you don't get into the subadventitial plane out there, it's very difficult to take them out. The second thing is that when you have these kind of tumors which are pretty high, Champlain 3 types and all that, what one would probably do is once you start going across into the bifurcation and then you gradually devascularize that part of the bifurcation, then gradually you see that the whole thing tends to start shrinking down. I think that's something which does help many a time despite not being able to see the distal internal carotid artery. So that's something that, I think you also must have faced a similar situation, that you don't see the distal internal carotid artery in the beginning, but once you start, separating it from the bifurcation, then gradually this tumor starts shrinking, and then you can see
we usually, if possible, we start to dissect them from external carotid artery in order to ligate and coagulate all the small feeding vessels. Then we complete with internal carotid artery, and at the end, turning down the glomus, we ligate the Meyer ligament at the bifurcation, and we remove it.
We have a different approach for the high carotid body tumors. We are now. We have a multidisciplinary team with the head and neck surgeons and the oral surgeons, and we go at a carotid mandible section in the midline, and we go high and we resect the tumor, and we already have around 7 cases done. And with the first patient we had a very difficult complication because of the glossopharyngeal nerve. So they get difficulty for swallowing. So we lost 1 patient because of conspiration. So now, when we do this approach, we never feed the patient until we have X-rays to see the deglutition. If they swallow well the contrast medium, or we feed by a nasogastric tube before. But this operation in team goes well.
But only for the biggest one?
For the ones who go up to the base of the skull.
Okay.
Oh, yes. So thanks to all for the...
The last question. When you have an aggressive tumor of Champlain 3, it's a huge tumor. We have been experienced trying to excise the tumor, causing damage to the nose, glossopharyngeal and hypoglossal. In those conditions, what do you think? Do you want to go aggressively excise the whole tumor, or you just want to leave back the nerve area so that you don't want to cause a disability to the patient? Like lifelong NT tubes, nasogastric tube intubation, feeding. What do you think?
I want to answer a question, or what we do is that usually when the tumor is so big, and probably they already have a deglution problem, they already have a deglution problem, and we want to release him of a big neck mass with compression. So those big tumors with resection, they go well. But you just have to be careful when you feed them. And you have to do an x-ray to see swallowing with contrast medium to see that they are swallowing well. If you're not sure about it, you feed them by nasogastric tube.
No, my thing is they are very aggressive involving the glossopharyngeal nerve. You want to leave behind the tumor part involving the glossopharyngeal nerve, excise the rest of the debulk, or you want to excise the whole tumor including the nerve. You want to leave behind the glossopharyngeal nerve damage to the patient, lifelong nasogastric intubation feeding, or you don't want to cause the damage to the glossopharyngeal.
The patient can go well even if you resect the glossopharyngeal, because in those tumors you don't see it. It's so big, huge. But if you have a physical therapy, language, and deglution therapy, the patient may damage the glossopharyngeal, but then you rehabilitate the patient afterwards, so they do well.
Usually when the tumor is so big and the nerves are completely involved in the tumor, they are still not functioning nerves. They are involved in the tumor, so we are obliged to cut sometimes. For example, as it happens with the vagal nerve. If you've got a huge vagal tumors, to have radicality surgery.
But the problem is, pre-operatively patient will have a good voice and good feeding.
Yeah, you have to inform the patients.
Yeah.
We will swallow it during lunch.
Okay, thank you to all for your presentation.
Okay, we have a very tight schedule here. We have lots of presentation to be done. So, starting towards the next session of aorta and iliac, in the chair we have Dr. Naresh, Dr. Mandika, Dr. Liu, and Dr. James. And in the panelist we have Dr. Wong, Dr. Marco, Dr. Mosata, and for the moderator we have Dr. Jun, Dr. Wong, and Dr. Jang Yong Kim. I request all of them to be seated accordingly in the chair, panelist, and the moderators. And starting with the presentation, we have the presentation of Dr. Frank.
Can we start? I think it's a video presentation.
Ironing the treatment of choice, despite 3 randomized trials showing otherwise. I have no conflicts, but like everyone, I have lots of biases. The use of endovascular tools and grafts in the management of ruptured AAAs is a concept we have had since we did our first EVAR back in 1992. That's because EVAR is intuitively better because it minimizes dissection, decreases blood loss, hypothermia, vessel injury, and coagulopathy. Fortunately, in the early days, we had available our own surgeon-made MAKES graft, which could be used in this configuration. This enabled us in April of 1994 to do the first EVAR for ruptured AAA in the world in this surgically inoperable patient. His aneurysm was successfully excluded by our MAKES graft, and the patient survived for more than 3 years, only to die of his comorbidities. Encouraged by this experience, in 1994 and 1995, we treated another 11 patients, all of whom were prohibitive risk for open repair. Surprisingly for us, in these 12 very sick patients, there were only 2 deaths, giving us a very low 17% mortality. These surprisingly good results led us to the hypothesis in 1995 that EVAR should be employed for all ruptured AAAs, even in good risk patients. From 1994 to 2000, almost no one else in the world agreed with us. They all felt that open repair was the best treatment for all ruptured aneurysms. So by 2000 to 2005, our and some other rare centers' results suggested that EVAR improved treatment outcomes for ruptured AAAs. However, some groups have had poor results with EVAR for ruptured AAAs. Notably, 4 controlled studies that showed that EVAR had no better results than open repair. So it's fair to say, as of 2009, EVAR for ruptured AAAs remained controversial, and there were many who said we needed a randomized trial comparing EVAR with open repair. We believe the treatment strategies, adjuncts, and techniques outlined in our 2009 Annals of Surgery article do make a difference and may account for the better results which some groups could achieve. Some of these key elements are to restrict resuscitation. We called it hypotensive hemostasis. We only place the large sheath for the balloon and inflate the balloon if it's absolutely necessary, that is if the patient crashes, and that is only so in about 25% of cases. When hypotensive hemostasis does not work and a supracoeliac balloon is needed, its placement is not simple. Technique is the key, and it's well described in this JBS article from 2013. Here shown is the balloon supported by a sheath via the left femoral artery, while the main endograft is being deployed via the right femoral artery access. Another top tip is to watch for and treat the abdominal compartment syndrome. I don't have time to go into the details, but they're mentioned in this 2009 JBS article by Lochat. And here's an example of such a case optimally treated. Despite all these points and our firm belief that EVAR is the best treatment for ruptured AAAs, however, this has remained controversial up until at least 2016, with many still saying randomized trials comparing EVAR to OR are needed, and 3 such trials have now been completed. These are the ECAR, AJAX, and larger improved trials. All 3 trials claim no difference in 30-day mortality between EVAR and open repair. However, that conclusion is, in my opinion, flawed, misleading, and just plain wrong. And here is why. The ECAR and AJAX trials both excluded high-risk patients in shock and too sick for open repair, and those are precisely the patients most likely to benefit from EVAR. How about the larger and better UK IMPROVE trial? The IMPROVE trial was a large multi-center trial, and its main conclusion was that a strategy of endovascular repair was not associated with significant reduction in 30-day or 1-year mortality. This conclusion was widely quoted on the internet and in Vascular News as showing no difference between endovascular and open repair. Here is why this conclusion is incorrect. Even though there was no 30-day mortality significant difference between the EVAR strategy group and the open repair group, one has to see the details to appreciate the flaws and improve. Time does not permit me to go into the many flaws and improve, but one key flaw is that of the 316 patients randomized to an endovascular strategy, only 154 actually were treated by EVAR. That's less than half. And their mortality was a low 27%, while in the same group, those patients getting an open repair actually had a higher mortality of 38%. So to me, it seems that the IMPROVE trial clearly shows that EVAR is the better treatment for ruptured AAA patients if it can be done. In addition, the most recent results from IMPROVE finally also confirm EVAR's superiority with better long-term survival with EVAR. So my conclusion is that the low EVAR mortality and the many inoperable cases that can be treated successfully by EVAR prove that EVAR is a better way to treat ruptured AAAs. Moreover, if the skills and equipment are available and the anatomy is suitable, EVAR should be the treatment of choice for ruptured AAAs in 2023 and beyond. Secondly, randomized controlled trials are not always the infallible holy grail they are thought to be. Sandeep, thank you so much for inviting me to this impressive meeting. Congratulations to you on putting it together, and thank you all for listening.
Thank you. We'll leave questions for lunchtime and get on with the next talk. Dr. Beatty, we talk about junction and AAA, Chiva and the fenestrated.
Thank you very much. You heard some very, very interesting talk from nobody better than Frank Beath, I think, who's a icon and a legend out here, and I think all of us literally revere him. I think there are two icons who were there. One, of course, recently passed away. That was Roger Greenhalgh. Again, another person who really went through statistics very well. Can I have a presentation, please? Yeah. Thank you. Yeah. So I'm going to talk about management of junctional AAAs. It's not working. Sorry. Yeah, sorry. So what are the options for junctional AAAs, which is basically the first, of course, the gold standard, especially in young patients, is an open surgery, which is there. Endovascular options, today we have a surfeit of choices, but then again you need to tailor the choices as per the patient rather than looking at all the options which are available today. One is the fenestrated EVAR. You have unfortunately in our country we don't have fenestrated EVAR available, so we use the physician modified endographs. Then you have the chimney EVAR, the sandwich EVAR, and branch devices, and of course the hybrid options of debranching. Again, these are of course something that we started doing about almost about 18-19 years back, and then in certain situations we do choose them. So what are the strategies for decision making? Of course, one would look at the age of the patient, the comorbidities, the aneurysm anatomy, origin and locations of the visceral vessels, because this is something which can be very complex at times, and competence of the surgical team, again, is very, very important, that you must have a team which is there to support you when you're doing these kind of cases. And I'll show you a recent case. Of course, this was a tough one. Although he's a young patient, a 27 years old male, a known case of hypertension bilateral. He had developed post-hoc paraplay paraparesis. He had intermittent abdominal pain, a history of open suprarenal aortic aneurysm, probably a Carroll's patch was placed at that time. It was done in a government hospital. And discharge summary and history was not very clear as to what kind of surgery was done previously, except mention of the Carroll's patch and a right renal artery aneurysm. He had a pulsatile mass in the abdomen. He had an LV ejection fraction of 50% with a global hypokinesia. The diaphragmatic, you can see the diaphragmatic paralysis is there on that side, so that is also got damaged out there. And he had duplex, on duplex also lower limb, we were not able to feel the pulses out there. Large aneurysm of about 12.4 centimeter length with 6.2 into 5.4 centimeter, and was just extending up to the celiac artery. Sorry. Yeah, so this is just to show you. Can we have the video please playing? Have the video playing? This one. Yes. So just to show you an image of that one, so one kidney only, and this is the large aneurysm out here. So what are the challenges, how to proceed, options and challenges? One was to repair of the aneurysm and preserving the SMA and the renal artery function. A redo surgery with a hostile abdomen there, large aneurysm, single functional kidney, and a paraparesis. Most likely it was post-aortic surgery, spinal surgery. Young patient, open surgery, redo surgery possible, but you were expecting a lot of plastering out here. Chimney EVAR was not really a preferred option because of the gutter leaks which were there. And a fever was a possible fenestration failure on long run due to aortic remodeling that could happen, and that's why these branch losses could be there. And branch EVAR was non-availability of a customized branch EVAR, as I mentioned, it's not available in India. So we had to do a little bit of working on this one, and what we did was we made our own branch device that was using a AAA device out here, which we deployed in the thoracic aorta. And one limb of the device, we basically connected it up into the distal part of the aorta. And the second limb, basically what we did was creating two parallel tubes out there, which we deployed into the superior mesenteric artery and the right renal artery, which was there. So this was basically the plan, and then after that we had to put in a... So this is what was done for this patient. So just to show you some angiograms out here, you can see this large aneurysm out here. So cannulating, what we do is that before we do anything, we just cannulate both the vessels, visceral vessels in the beginning, so that at least then you can, once you're going through the endograft, then you don't have to really search for the openings of those arteries out there. So we cannulated all those vessels. We deployed the proximal part of the endograft till the contralateral gate was open, and then after that we recannulated through the endograft from the short length of the graft from there. And then after that we balloon dilated, and then we deployed the stents out here. Both the renal and the SMA, we used the fluency grafts out here because we required long lengths out here. And then of course did the ballooning, and this you can see SMA. And then after that we put in a flared device, which is a bell-bottom device out here into the abdominal aorta out here. So we had flow restored, balloon dilated because there's a big narrowing out here of the aorta in the infrarenal part out here. And then of course at the end of it we had flow going across nicely with no endo leak. Subsequently this patient came back. In fact we do a contrast enhanced ultrasound. The aneurysm has practically disappeared now completely. Another patient with a 75 years old male, incidentally diagnosed with AAA, again large fusiform aneurysm out here. So here we plan to do, with his comorbidities and all, we decided to do a percutaneous triple chimney device via the bilateral renal, that is via the bilateral CFA and bilateral brachial and left axillary approach under GA. So that is what was done in this particular patient. Very, very angulated anatomy, so not a suitable case for putting in a fenestration out here. So we did this, putting in chimneys in both the renal arteries and the SMA. And then after that, once we had the stent graft deployed, this came off very well. This patient has been under follow-up for almost about 3 years now, and no endo leak, and he's doing well. Case C was a 71 years old male. Now he had another problem, that he had an aortoiliac stent done before, and the right renal artery stenting and juxtarenal AAA. So here what we decided to do was percutaneous double chimney EVAR via bilateral brachial and CFA approach. And again, first we had to do an instant ballooning out here for the endograft to pass through. And this is what the angulated anatomy looks like. So again, we cannulated the renals out here, and stent graft was positioned, and you can see out here, no endo leak out here in the final run. This was another tough case which came to us, a 71 years old female with repeated history of Takayasu's arthritis and abdominal aortic aneurysm. Again was on steroids and everything, and then she came with acute kidney shutdown out here with a high creatinine, and then she had already been diagnosed earlier for a left renal artery stenosis, for which nothing was done initially. But then subsequently when she came back, she came with a high creatinine, and then was put on dialysis and all at that particular time. And again she had a large aneurysm. So this is what the image was. The right renal artery was completely narrowed, 99% stenosis. So initially we thought that we will tackle the aneurysm at the same time, but then I think discretion was better part of valor, because with her being on dialysis and all, we didn't want to take a chance of tackling anything else. So first stage what we did was we did a stenting of the right renal artery, and then we got a good result with that one. Her creatinine came back to normal and all, she was absolutely normal. We did a CT angio subsequently, and that again showed that there was a fusiform dilatation out here. So then after that we planned to do a triple vessel fenestration for her for celiac, SMA and the right renal artery. And again we used all the three accesses out here, cannulating the renal vessels. And then of course this is what we do on table. We create or make our own fenestration. We look at the CT angioaxial images, and then after that we make our fenestrations out here for the celiac and SMA at 12 o'clock position and the right renal artery at 9:30 at that particular time. And then of course the most important part, as you all know, is basically positioning the device out there so that your fens fall into place at the appropriate level that you want them to be in. So then after that, cannulating the fenestration, both the right renal and the SMA fenestration. And once we got that, we released the top cap. Then we put in some constraining sutures also. We removed the constraining sutures once we had the sheets inside. And then after that, we deployed all the stents. So cannulation of the celiac artery was done right at the end, because first we wanted to finish off the SMA and the renal, and then we got it right, and this is what the whole picture looks like. There's no aneurysm seen, and all the vessels were nicely filled up out here. So this is of course our Dyna CT image out here. As you can see, all the branches out here nicely seen. Again, she did well. The last case which I will show is a 69 years old male. Came with breathlessness, for which was evaluated as NCCT and diagnosed with a juxtarenal aortic aneurysm. And again, this was the aneurysm. This was just done about 2 or 3 weeks back. Now the challenge was he had this huge aneurysm out here with severe breathlessness, pain abdomen and all. And there was a challenge because at that particular end it was not very obvious, but I'll just share this picture. As you can see, a large aneurysm out here. So we decided to do an EVAR with chimney of bilateral renal arteries and fenestration of the SMA via the bilateral groin and bilateral brachial and left axillary position. So we did our diagnostic angios and everything, cannulated the vessels, again all 3 vessels out here initially, and then of course creating our fenestrations out here, and then of course deployed the stent graft up to the SMA fenestration. So we did all this part, of course, all the fenestrations went off very well, and we thought that we were home and dry. Everything was good because we got all the 3 vessels going. And then the next part came where the contralateral device, and we saw that opening up with the contralateral device where it opened up. There was a tight stenosis in the aorta, as a result of which this just opened up on that side, and there was no wire which would be, we could advance it across the bend. We tried everything from ballooning, going across, but even a wire could not go. We tried going from top, bottom, but probably there's a very, very tight stenosis out there. And then of course, the only bailout which was left under the circumstances was that we went across from the left side, deployed an Amplatzer plug, and we did a fem-fem bypass, and we came out. So this is what was done. And so in these kind of situations, you really got to look at all these patients, and as I mentioned, that you really need to tailor the strategy as per the patient and try to get the best results. And this patient also, we've got his contrast and has ultrasound done at 1 month. The aneurysm has already shrunken to quite a large extent. In fact, the patient is doing well, and creatinine and all parameters are normal. So thank you very much for the opportunity.
Thank you, Dr. Bedi, for that interesting presentation and excellent outcomes. Next is Dr. Thomas talking about thoracoabdominal aneurysms, open approach.
Thank you very much for the invitation. I'll try to tell you a little bit about open surgery for thoracoabdominal repair. And you will see it's not the right presentation. It's still something which we'll need to do despite all the advances of endovascular surgery. Yeah. Okay. That is correct. Oh, this is not the correct one. I will share you that I don't have a prejudice against endovascular open repair. I've been the first one in my country to do it. That was back in 1995. So it's more than 25 years out. It's the wrong one. This one now. Okay, great. Thank you very much. Thoracic abdominal aneurysm is a condition in which the aortic aneurysm involves the segment of the aorta where all the important branches of the intestinal arteries take off. And also these aneurysms used to tend to go higher up to the subclavian artery or go down to the iliac bifurcation. Actually, the surgical problems are access to the aneurysm, which can be quite difficult. Reconstruction of the visceral arteries, either as a patch or as single grafts. Perfusion of the visceral arteries during cross-clamp. Preventing paraplegia by reimplanting the lumbar arteries. And perfusion of the spinal cord. This is the initial presentation of Mike DeBakey about thoracic abdominal aneurysm. And I can see from his drawings from this article that things didn't change very much in the times of homograft repair and up to now. This is the shunt he used as, from a femoral artery and the huge aneurysm in between, which could be clamped by preserving the perfusion to the legs during repair. We have four types of thoracic abdominal aneurysms. The one which start at the subclavian artery, go down to the visceral branches. The one involving all the aorta from the subclavian artery down to the iliac bifurcation. Actually, that's the most frequent type we see. Then type 3, ranging from mid-descending aorta down to iliac bifurcation. And then the easy ones, the type 4s, coming off from the visceral segment. For type 3 and 4, usually you don't need to open up the thorax. You can widen up the entry of the aorta through the diaphragm, so you don't need to go into the thorax and divide the diaphragm. And you can either use an end-to-end anastomosis, the top and the patch, or this combined approach as for type 4 aneurysms. The surgical aneurysms, the surgical access for the more common ones, the ones who go up to the thorax, involving thoracotomy, depending upon the extent of the aneurysm, you go higher up to the fifth interspace. The management of the diaphragm is very important because you have to continue to have function of the phrenic nerve. So you do a radial incision of the diaphragm and avoiding the center of the diaphragm where the phrenic nerve enters into the diaphragm. Usually you do this only for type 1 and 2 and occasionally for type 3, not for type 4 where it can stay entirely in the abdomen. The progression of the disease is a very important factor, to my opinion, because according to this patient who has got a post-dissecting aneurysm, and there is a CT scan 5 years in between. And the first CT scan, the patient was 78 years old, and the next one, he was 83 years old, and that's very close that you don't do any surgery anymore, even in our country, and the aneurysm hasn't grown so much. So probably he will end up having no surgery until the end of his life. And I think you have to be very, very concerned about the progression of disease in these cases, because you can avoid a huge procedure no matter if it's endovascular or open, for these patients. One of the main important steps in these procedures, especially for the big aneurysms, is the use of a left heart bypass. You can either use it with a pump, either taking off the left auricle or even higher up. That's usually the cardiac surgeon's approach, and I often do these procedures with the cardiac guys. But you also can do passive, like in this case, this is my last type 2 I've done, and you can see still the catheter. And this is passive shunting with a bypass from the axillary artery down to the femoral artery with side branches for perfusion of the visceral vessels. That's what I do when I don't have any cardiac machine available. In some hospitals I don't have this. This is a type 1 post-dissection aneurysm. You can see the huge dissection aneurysm in the thorax and a much smaller aneurysm down in the abdomen. So actually we performed selective operation only with the thoracic part. Like in this, you see the access for the heart-lung machine, the big aneurysm across the heart, and the post-op repair with a patch down to the visceral vessels. This is a type 3 aneurysm with impending rupture. You can clearly see the blob of the aneurysm in the abdominal part. The renal artery is on the right side of the image. This is the post-op repair with reimplantation of the left renal artery. Sometimes, if the left renal artery is very short and the aneurysm has a very big configuration towards the left side, you need to use a graft in order to reconstruct the left renal artery. This is a type 4 repair, very easy. The aneurysm starts just at the level of the celiac axis. This is the repair. You can see the anastomosis at the top, which is reinforced, and the reimplantation of the renal artery. Type 2 repairs. This is done. This case has been done with a passive shunt, and here you can see the repair with the patch anastomosis and a graft to the left renal. So these were the old cases where you would do a primary surgery for these types of aneurysms. But there are future developments which require still open management, like this case. This case has an aneurysm up to a type 3 aneurysm with branches taking off and chimneys, supplying the arteries, and you can see a huge endoleak beside the chimneys. And when we repaired it, we found that these chimneys were infected. So actually, we ended up doing an interposition graft with a lot of vein bypasses to the intestinal arteries. This here is the renal vein, superior mesenteric artery. Let's go into the celiac axis. So you still need open surgery knowledge in order to do these cases after endografting. This is another patient with endograft. It's an infrarenal endograft. The patient developed a type 1 endoleak and extension of the aneurysm cranially. We wouldn't do a debranching from the external iliac. So we did the debranching from the thoracic aorta down through the diaphragm, you can see here, and then stenting through and through up to the subclavian artery. And this patient was operated 8 years ago, is still alive and doing well. So I think these kind of things you can do, and it requires open surgery skills, still open surgery skills. This is a patient who underwent an thoracoabdominal endograft with the Nelix procedure. And you can see the huge endoleak here, supplying the inferior mesenteric artery. And you can see that interruptive venous aneurysm is really big. This is the abdominal part. We had to clamp the aorta from above with a balloon because you cannot clamp the endograft. And these kind of endografts are extremely difficult to stitch. Actually, we used wires, small wires used for veterinary surgery to stitch the graft to the endograft, and used some extension grafts to the intestinal arteries. This is a post-op image. You can see clearly a good extension of the huge aneurysm in the abdomen. Unfortunately, this patient died on day 32 due to sepsis from fungi, but otherwise you can do these kind of procedures. They're very demanding and need a lot of general surgical and endovascular skills. So in conclusions, I think open thoracoabdominal repair will have a renaissance because endovascular repair is not always possible. Secondly, complications of endovascular surgery are often not possible by the endovascular way, so you have to do some kind of hybrid procedure or a total explantation of these kind of grafts. Actually, 50% of my thoracoabdominals I do now is correction of failed endografts. Connective tissue diseases like Marfan's, Ehlers-Danlos, or Loeys-Dietz are still better served with open surgery. And the problems of the procedure are patient selection. That's the most important thing. Then procedures should be confined to big centers where they do a lot of these procedures. In Europe, this is, for example, in Maastricht or in Aachen. These do a lot of these procedures. If you do less than 10, 15 a year, you probably should send these patients away. Thank you very much.
Sriram, your next batsman in.
Thank you, Thomas, for that lovely presentation. It's nice to lead on straight from there because he's quite right that endovascular is not the answer to everything. You do need to have a lot of open surgical skill. Much of it has already been covered, so I will be able to run through fairly quickly. The first thing to understand is that just because you achieve technical success in your CT scan today doesn't mean your outcomes are going to be great tomorrow. This is something to remember in endovascular. The other impression that's been given to a lot of people is that smaller the incision, the better the procedure. That is not quite true. You have to have discussions with your patient. Do you want to die from a rupture in 30 minutes, or do you want to be paraplegic for 30 years? It's an important question to ask. And just because you can do the procedure today, because especially with radiology heavy units, so to speak, you can technically manage to wire and put stents into places. Would you be able to manage the complications that occur tomorrow? And Thomas's presentation and the fact that 50% of his thoracoabdominal open interventions are now failed endografts is a warning. And so don't gloss over the risks when you take consent just because you want to do a complicated procedure and put some CT scans up in a conference. That's not the reason for doing these procedures. So the classical classification for thoracoabdominal has of course been type 1 to type 4. The Crawford, we modify it a little bit for the sake of endovascular repairs. And the issues with open surgical repair, even in the best units with thoracoabdominal repair, there is spinal cord ischemia. You do get stroke in these patients. Acute kidney injury occurs, cardiac events kill people, and there is a fairly high hospital mortality. And even in the best units in the world, you will have these complications and mortalities that occur.
The type of aneurysm does have a significant impact on the mortality. How many vessels and visceral vessels do you need to sort? It changes the spinal cord ischemia risk, it changes the duration of the procedure, it changes the coagulopathy of the patient, and you really need to be prepared for all aspects of this when you decide to undertake even endovascular repairs. Again, it's a fact that if you get a good, successful open surgical revasc, very few revascularizations are required down the line. You should be able to do all these adjunctive measures that Thomas mentioned, left heart bypass or cardiopulmonary bypass. You should be able to do a hypothermic circulatory arrest. You should have a CSF drainage plan. You should be able to monitor, we used to monitor with evoked potentials, now we do cerebral oximetry throughout all our carotids as well as thoracoabdominals. And you should be able to do selective perfusion of the visceral vessels and cool them down. I'm not talking now about open repair alone, I'm talking about having the ability to do all this when you are undertaking a complex endovascular thoracoabdominal repair. What I'm basically saying is if you're going to do a complex thoracoabdominal TVAR, be prepared to convert to open and have every facility you need to convert to open, which means you should be skilled in both. So there are some technical issues, and the technical issues with endovascular repair really relates to two basic things. Landing zones, the proximal landing zone and the distal landing zone. And the second thing is spinal cord ischemia. So those little red spots tell you where you don't have a top-end landing zone and where you may not have, you have the risk of spinal cord ischemia from coverage. Also remember, a type 4 thoracoabdominal aneurysm and a proximal junctional EVAR are not quite the same. They are two different beasts. Once you start doing a T7 to L2 coverage, your risk of complication really goes up. Your cross-clamp options in thoracoabdominal aneurysms are absolutely not easy in an unprepared environment. Your patient is in the wrong position, you do not have CP bypass available, you do not have the option of circulatory arrest, you do not have a thoracotomy, you've not prepared to have a diaphragm sparing or phrenic nerve sparing diaphragmatic approach. Brachial manipulation that is required in thoracoabdominal in doing a TVAR through the subclavian, it does carry a significant stroke risk. And the follow-up is genuinely for life. The fact that you've got a few good pictures and sent the patient away after a couple of days or 3 days does not mean the game is over. These aneurysms continue to evolve or can evolve. The aorta remodels, and what looks good today will not look good after about 1 year. So be prepared. This is a standard EVAR. These are pictures of a standard EVAR. They all look very nice. Things go up the groin. Stent lands beautifully. If it's a little junctional, you can chimney, you can do endo anchors. These are fairly easy to deal with. The fenestrated EVAR, the neck length does not allow you to do a standard EVAR, and therefore you don't have a proximal landing zone. But the problem with doing a fenestrated EVAR is, as far as possible, the ostia of the graft itself have to be in contact with the ostia of the vessel. So if your ostia of the renal vessels are going to be in aneurysmal zone, then a FEVAR is not really a good option. The aortic diameter at the ostia should not be less than, needs to be less than the proposed stent diameter. And now you can only do a proper FEVAR, but not all the visceral arteries are arising from the sac. So really you're doing a junctional EVAR where the anatomy is unsuitable for a standard EVAR. So you're going for a FEVAR. The branched EVAR comes into game in thoracoabdominals when, of course, as Dr. Bailey showed, you have the visceral vessels which are actually arising from the sac itself. And you have a few branched options. There was the Zenith branch device, it's the Tamway device from Gore, which is not available in this part of the world because Gore has disappeared and retreated itself back into the United States. And the Valiant thoracoabdominal graft was Valiant for a while, but it has been withdrawn from the market for its complications. So if you look at the outcomes of endovascular repairs, they're fairly good, but the freedom from all-cause mortality at 3 years is only about 57%. And so you are choosing a bad group of patients. It's not that you're getting a 90% survival in 3 years. It's only about half the patients will be alive after 3 years. And that's usually because they have significant comorbidities. The aneurysm-related mortality doesn't seem to be affected by the aneurysm type. So you can have complicated aneurysms and that doesn't cause them to die. But the more complicated the aneurysm, the worse is the patient around the aneurysm, and so their mortalities tend to be high. Reintervention rates are much higher in these patients who have specifically the type 2, which is arising from the arch itself and involves whole of the visceral vessel architecture, and overall intervention or freedom from secondary intervention is only 56% at 36 months. Most of the time you're doing re-interventions in these thoracoabdominal fevers, endovascular repairs, because you have threatened target vessel patency. So a pure endovascular outcome from the Cleveland Clinic analysis, a pure endovascular approach may not be the only option in these thoracoabdominal aneurysms. The E-Inside device which has come out, which is essentially a device, used to be called the Colt device, is based on the barrel of a Colt revolver, so there are 4 holes in it, and it allows you to do this custom-made approach, but there are a couple of problems in it. All 4 visceral vessels have to be involved and be within the sac to use this device, and you have to understand that you will get about 115 centimeters, which is a lot, millimeters, with about 10 centimeters of proximal coverage of the thoracic aorta, which means the spinal cord risk is real, however you treat this device. So it's a great off-the-shelf device to use, but spinal cord protection is the key. I think it's my alarm going off saying I should get up. Okay, so the E-Inside branch is great as long as the anatomy is suitable. So even though the E-Inside has been presented as this custom device that can be used pretty much in every thoracoabdominal aneurysm, that is not quite the case, and be prepared to do spinal cord protection in these patients. That's what the device looks like. So instead of the branches being on the outside and the fenestrations being on the outside, they're on the inside. And if the aneurysm is suitable for it, it's an extremely easy device to use rather than do complicated fenestrations and scallops and P-branch and T-branch devices. So it has various stent graft configurations, but most of them are off the shelf and it is fairly easy to use. But this is my preferred approach. I have a low threshold for hybrid repairs, which is to say that if I cannot safely endovascular handle a visceral vessel, I will be prepared to do a hybrid revascularization of that vessel. I tend to debranch generously, especially in terms of the subclavian or a carotid subclavian bypass. I'm happy to do staged repairs, where I will do the top end stage, let the patient recover, and then go back to doing the abdominal approach. CSF drainage is mandatory for me when you're doing a thoracoabdominal, but I also tend to stage the CSF drainage, which is do it the day before and make sure there is no spinal hematoma and things, because the worst thing is you prepared yourself for the whole procedure and then you get a spinal cord hematoma that you're not prepared for. And I prefer to use bare metal stents at junctions if I have to, rather than covered stents. Never use bare metal stents at the upper end, though, to extend it into zone 0 and zone 1. So you can do a total debranching and then do a full TVAR. You can do a partial debranch and then do a TVAR. You can do a left subclavian transposition and then do a TVAR. You can ask yourself, is left subclavian revascularization always necessary? If the 2 carotids are disease-free and the vertebrals are disease-free and you don't have any retrograde flow in any one of the vertebrals or they're not hypoplastic, then possibly a left subclavian is not required, as long as the internal iliacs are being kept open. That prevents the spinal cord ischemia as well. There are many options to visceral debranching. I prefer the third option, which is to do the 2 renals from one of the iliacs if possible, and to use the other iliac to do the SMA. This seems to be the simplest technique for me. But the key takeaway is to build a team. You need a team where you're an anesthetist, you're neurologist who's going to help you monitor your intensive care team, your coagulation team. They all work together. It's also important, of course, to know the right people, as I will show you. So that's not moving. Yes. So that patient is probably one of the most difficult repairs I've done. He had a carotid subclavian bypass to start with. 3 days later, we went in to do a TVAR with spinal cord protection. His both renal arteries, as you can see from below, is bifurcated from the right external iliac. From the left side, the SMA, the celiac, was already occluded. Why did we decide to go ahead with this patient? He was done in Brunei. He used to look after the 3 favorite racehorses of the Sultan of Brunei. So the Sultan insisted that he's done in Brunei. And in return for doing this, I will go back to the previous slide, if I can. Because we did this successfully, the Sultan gifted us a hybrid theater in Brunei for 3 million. So it's important to know the right people as well. He did have paraparesis for about 30 to 40 days. Took a bit of rehab to get him walking again, but he's back with the horses now. So thank you very much.
So it seems that the next presentation will be shifted at the end of the session for a technical reason. So I'm going to call Dr. Alberto Munoz for aortoiliac aneurysm open approach to branch devices. Next one, okay. We'll go on with Dr. Franco Grego. It's a really big pleasure from my side to present him. And the vascular treatment post-EVAR endoleak. No, sorry. Aortoiliac aneurysm open approach to branch devices. So I'm asking to you please to respect the time because we are out of time.
Okay, thank you. Thank you again, Sandy, for the invitation. I have not discussed the next I have here, sorry. I have not a potential conflict of this presentation. So several societies have suggested to treat abdominal aortic aneurysm when they achieve 5.5 centimeter. But we have to consider other aspects in order to decide for the surgical criteria. For example, age, the morphology of the aneurysm. A sacral aneurysm is totally different than normal aneurysm. The dimension of the sacral aneurysm might be less than 4 centimeters and require the treatment. The growth rate is another aspect that you have to consider for the surgical criteria. And all of these consideration is in a relation of the mortality rate that you have in elective repair that come from 2 to 5% in relation with the mortality in the rupture that might be from 25 to 60%. So the question is always the same. When it is indicated to perform an endovascular treatment and when it is better to perform an open surgical treatment. But more and more the question have to be, which is the role of the open surgical treatment in the adult AAA field today? EVAR represents the first choice because it's characterized by the lower early morbidity and mortality, because of the shorter length of the hospitalization, not more than 2 days, fast return to daily life activities, and good long-term outcomes, in particular with the new devices. But when is open repair recommended? I think that open repair is recommended in selected cases, in particular in young low-risk patients, so in elective, obviously, abdominal aortic aneurysm repair. In challenging cases for EVAR or FEVAR, is the only solution for infection, and is one possible solution when we have one post-EVAR complication that without other endovascular option. So you can see our flowchart for the surgical criteria for abdominal aortic aneurysm today in my department. You can see in blue that we suggest open repair also in low-risk patients with unfavorable anatomy for EVAR. And also in case of a favorable anatomy for EVAR, when the patient is young, so less than 65 years old, or when the morphologic characteristic of the aneurysm can prevent to have one high risk of type 2 endoleaks. In high-risk patients, we suggest to do the open surgical treatment, accepting the higher risk of this procedure when there is not possible one endovascular solution. So, despite the best performance of the last devices, the patients with an osteo neck present a high risk of type 1 endoleak, high risk of the reintervention, and also high risk of the mortality aneurysm related. But not only at the neck problem. There is another level of the problem, is that the common iliac arteries involvement, like in this imaging. When you have a case like this, on a bell-bottom technique, in my opinion, it's not a good idea. Probably, if the anatomy is favorable, you can do an iliac branched endografting or an open surgical treatment that can resolve perfectly the case. So the conventional repair, open aneurysm, are performed primarily in patients who are not anatomically suitable for EVAR or FEVAR. And there is a linear increase in the percentage of the AAA, the repair requiring suprarenal clamping. This is a particular case with a sacral aneurysm at the level of the origin of the renal arteries, and we treated this patient more or less 10 years ago when we were starting with the first fenestrated endografting, but we chose in this case an open surgical repair that required a supraceliac aortic control, and the final reconstruction required also a bilateral aortorenal bypass. Probably today, with the new experience with the fenestrated graft, probably in this case, now we should choose one fenestrated graft. Supraceliac aortic loss clamping. This is a great, maybe a great problem for the young surgeon that don't have the skill to treat this level of the aorta, but I think that it's very important to teach to our young collaborators this maneuver. It is very simple. You can see that you prepare the left portion of the liver, arrived to the celiac, over the celiac axis. It is necessary to cut the muscle of the diaphragm, and after you have the normal space to do the control of the aorta, like you can see in this picture. So obviously, when you speak about pararenal aneurysm is one thing. When you speak about fourth-type thoracoabdominal aneurysm is another. The fenestrated graft probably now is the best solution. Diameter of the renal artery. The anomaly, for example. So there are some cases when a fenestrated graft is not possible. So in this case, obviously, the open surgical procedure. And another important thing, you know that today we are using often 4 fenestrated endografts. Aneurysm. In this case, my question is normal renal artery in relation with a normal renal artery stented. I think that is a worth consider also this aspect. In case of to treat, like in this case with an fenestrate endograft, it is necessary an open conversion. An open conversion present an perioperative the patient. And normally this patient were excluded for open surgical treatment because the conversion you can do the operation without problem. In this case, to maintain the first stent of the endograft, so you create a neo-neck where the suture line include prosthetic graft, aortic wall. This is not possible in case of infection. In infection, it is mandatory the radical asportation. So in conclusion, EVAR represents the first option for the treatment of the abdominal aortic aneurysm, but open surgical repair maintains thanks to its efficacy and long-term durability. It is the primary choice in young patients, in my opinion. It represents the preferred choice in low-risk anatomy, so unfavorable for EVAR. Is the only solution for infection, and is also the only solution when there are without any other endovascular treatment. So it is very important to have a great experience in both fields in order for our patient. Thank you very much for your attention.
Thank you, Professor Grego, for respecting